Good morning, everyone, and welcome to the fourth Wisconsin Brain and Spine Metastases Symposium. It's my great pleasure to welcome you to the state of Wisconsin virtually. We're lucky to have two great academic institutions in the state of Wisconsin, UW-Med and MCW. Between the two cancer centers and collaboration with our community oncologists, we provide comprehensive cancer care for the entire state and beyond. Our goal in creating this educational activities to improve cancer care for Wisconsinites by providing updates from leaders in the field of neuro-oncology on cutting-edge development in terms of surgical advances, clinical management, and innovative clinical trials in the field of brain and spine metastases, while also integrating patients' perspective.
Thank you, Dr. Day. It's a pleasure to be here again. My name is Joe Bobie. I'm a volunteer faculty member at the Medical College of Wisconsin. Everyone in our virtual audience today recognizes the burden of brain metastases presents to patients with a diagnosis of cancer. Brain metastases will be the #1 malignant intracranial tumor diagnosed this year. A more concerning fact is that incidence is on the rise. While the emergence of targeted and immunotherapies has rendered many patients free of disease outside the central nervous system, we are still seeing the central nervous system act as a sanctuary site for metastatic disease. We are delighted to virtually host this expert panel this morning, and we will hear from them today about the advances being made in the diagnosis and treatment of central nervous system metastases. Before we get started with our first speaker, Dr. Fecci, is a bit of housekeeping. For those of you who are not familiar with the WebEx platform, there is a question mark in the lower right-hand corner that is actually a QA box. As the speakers are speaking and as your questions arise, Dr. Day and I will moderate that box and make sure that those are answered. So don't hesitate to click on that and write your questions down, and we'll make sure that those get asked of our expert panel today.
Thanks, Dr. Bobie. And now I'm really excited to present our first speaker, Dr. Peter Fecci. Dr. Fecci is a professor of neurosurgery at Duke University. He's the director of both the Brain Tumor Immunotherapy Program and Center for Brain and Spine Metastases at Duke University. And today he'll be discussing the role of LIT for management of brain metastases. And I've known Dr. Fecci for a while, and we follow each other's work for a while, and it's a great pleasure to have you here today.
Thanks for that. I really appreciate that, as well as the welcome and also the opportunity to be here with you. It would have been my first time in Wisconsin, so I'm sorry not to be there in person, but I'm happy to be here virtually and be able to share some of our thoughts with you. We've been one of the larger users, so.
Person.
Yeah. We'll make it happen at some point, no doubt. So one quick question that I wasn't aware of this, and so I'll just ask now. I know that we had sent our presentation, so I wasn't sure if I was just sharing from my computer or if you guys were pulling it up. I'm happy to do whatever, obviously.
You can go ahead and share it.
Okay, all right, just making sure. Okay, let me get rid of all this stuff here, and I will pull up my talk. There's so much stuff on my screen. Perfect. Okay. All right. Do that. And great. All right. Are you all seeing a presentation?
Yes.
Yes,
You are. Okay. All right. And does it look like it's on lit potentially?
Yep, it all looks good.
Okay. All right. Okay. All right. Perfect. So yeah, again, thanks for having me. This is hopefully going to be an informative talk on where I think LIT fits in neuro-oncology. We started using this technology back in 2015 and rapidly have become really one of the busiest centers for it. But I think that, like any new technology, it takes a little while for people to figure out exactly what the correct uses are. And of course, there's hesitation on a lot of folks to adopt something until that's clear. And I think we've done a pretty reasonable job of figuring out what the best uses for LIT are. And hopefully I can share some of that with you today. As a disclosure, as a kind of large user of this, perhaps it's not surprising that I do have a consulting agreement with Monteris which is the company that makes the NeuroBlate system, which is what we use for the laser over at Duke. So what is LIT actually? And the acronym does stand for Laser-Induced Interstitial Thermal Therapy. And admittedly, the idea of using heat in medicine is not new. In fact, we can trace this all the way back to Hippocrates. But clearly, this technology and this implementation of heat is new, or at least newer. And it really is a minimally invasive surgical approach. And I think it's really key. I'm going to drive this point home is that this is a surgical approach, and this is an alternative to open resection. It is not an alternative to things like radiotherapy. In fact, if anything, it's to be used in conjunction with that. And what do we mean by minimally invasive? It's essentially a stab incision. It's very much the same workflow and incision as one would put for a stereotactic biopsy. And basically, it's that size of a surgery. And we do typically biopsy every time we do this procedure, and then we simply swap out the biopsy needle for a laser catheter. That laser catheter has a diode at the end of it. You can see there's two types of laser catheters with the NeuroBlate system in particular. There's one that has a full fire in which heat is emitted in all directions, and there's something called a side fire, which is what I use exclusively, where the heat is emitted in one direction, and there's a robotic control that can change the depth of the laser in the patient's head, as well as spin the laser to essentially push heat out more in one direction in order to sculpt a lesion from the inside out. And so once that laser is placed in the lesion, we do this in an intraoperative MRI suite where we roll the MRI out over the patient. That MRI is switched into essentially a giant thermometer, and we're able to get temperature data that allows us to determine in conjunction with a software package that a lesion has been killed or stunned, et cetera. The beauty of this is that most patients go home either the same day or the next day, and increasingly since COVID, we started sending patients out that afternoon. They typically leave basically with a Band-Aid on their head, and most of them are essentially unable to tell that they've had a surgery, despite the fact that we've offered them some cytoreduction. There are two technologies. There's actually a third player now in the market, but predominantly it's been two technologies to date. The Monteris company makes the NeuroBlate, and the Visualace is made by Medtronic. As you can see here, I will mostly discuss NeuroBlate just because that's what we're most familiar with. Key points: LIT is a minimally invasive surgical technique. That's the thing that I was driving home. This is an alternative to an open resection, so it is not an alternative to radiotherapy. This is not to be swapped out for SRS, but to be used in conjunction. And the strongest programs really are a collaboration between neurosurgery, radiation oncology, and medical oncology. Uses and considerations. So there are a variety of places that LIT gets used, often in neuro-oncology, often for mesial temporal lobe sclerosis or epilepsy. I will obviously discuss usages in tumor today. I will focus on metastasis, but I will cover glioma briefly. And then radiation necrosis, which is obviously something we face in the metastatic arena, is another really large use for the system. A key point here, this is not a panacea. This is another tool in the surgical toolbox. And the problem, of course, it's the old adage that when you have a hammer, everything starts to look like a nail. But of course, there are plenty of screws out there, and you have to choose the right tool, or you could end up doing something very bad. So what are some of the considerations here? First off, in general, if you're going to use a single trajectory with the laser, you need to treat lesions that are under 3 centimeters. You can do multiple trajectories, but this does cause some swelling. So if you're going to do that and cause some more swelling, you have to be comfortable with where you're doing that. I would say that in general, most of the place that I'm doing 2 trajectories is like, i.e. right frontal lobe. Do we know how much of the lesion you have to cover? It turns out there's some data retrospectively that matches the resection data, which is that, in general, if you can get more than 80 to 90% of it, that's going to offer some benefit, but you're looking for maximal safe coverage. It will cause some edema and mass effect. You will need some steroids for a period of time after the surgery. Superficial lesions can create some artifact. The dura and of course the titanium bolt that we introduce can make it sometimes hard to see the heat traveling through a superficial lesion in the software package. There are some fixes for that. We've become better and better at doing this. But that's another consideration that might make you favor craniotomy at times. Heat will follow certain trajectories, and I call the rule of V's ventricles and vessels. So water has a high specific heat. Things that contain lots of water will pull heat away and potentially make it difficult to heat something that's bordering a large vessel or the ventricle, but you can still get most of it for sure. You have to understand trajectory planning, and of course, there's a learning curve with the technology. And as with everything in this world, the biggest problem is, of course, neurosurgeons. We're the worst. And now we're like a kid in a candy shop because you've given us a new toy, and that toy happens to be a shark with a freaking laser beam attached to its head. And so we do stupid things with it. And so you have to kind of keep us in check. So what are some of the ways you need to keep us in check? Well, these are some of the pause buttons that people should think about. So first off, we just talked about the rule of V's. If you're along a ventricle, you may have trouble heating the very edge of the lesion that borders that ventricle to a kill temperature. Superficial lesions do create some artifact, but we can place the bolt in a more shallow fashion in the bone. There are also ceramic bolts now. All those things allow there to be less artifact through the lesion. The only hard stop here is this lesion on the right. This is someone that you can see is already herniating. This is a large angiosarcoma met. If you put the laser into this and cook it, you will kill this person. You cannot do that. This has to be resected. This is not the correct use for the laser. So there are some gold standards in what we do in neurosurgery and neuro-oncology. In the case of GBM, that is surgery plus the Stoop regimen. And in the case of metastatic disease, that's SRS plus or minus resection. But there are plenty of places where there's no gold standard, and I would argue that this is where the laser comes in nicely. So in GBM, it's those patients that are ineligible for Stoop, maybe patients that are elderly, have a low KPS, which is all told probably more than 30% of your practice. Recurrence, patients that, 100% of these tumors recur and there's no standard of care here. And resection is often no fun in these patients. Poor wound healing, radiated scalps, the dura is stuck to the brain surface. Those are all not ideal places for resection, and this is where the laser can be quite nice. And in the metastatic arena, it's patients who fail SRS, either due to recurrence or radiation necrosis. All these folks also, surgery can be sometimes no fun, scarred, stuck lesions, poor wound healing, all the same things that you face in recurrent GBM. So you can imagine that that's where I'm going to start to tell you the laser has potentially a good role. So I'm going to go through some of this in more detail. And I'll go through the glioma section pretty quickly since this is, of course, a metastatic conference. But what is the standard of care for gliomas? Well, this is pretty simple. Newly diagnosed GBM, it's maximal safe resection if able, and then the Stoop protocol if able, which is, of course, temozolomide plus radiation. The key point here being if able, so you have to be able to do all of these things. And I think there's a really important thing if we hearken back to the original Stoop paper back in 2005. And I think people forget this, but the fact of the matter is that there are a variety of people that receive no benefit from the Stoop regimen. So who are those people? Number one, those are the people getting biopsy only. So if you are only able to biopsy somebody for whatever lesion, that person will really get no additional benefit from the Stoop regimen over just radiotherapy alone. And additionally, people with poor performance status. So if you leave someone with a poor KPS, those people are also likely unable to get much benefit from the Stoop regimen. So what could the role for LIT here be? Well, the fact is that not everyone gets standard of care. And there may be people that are only getting biopsy or partial resection for a number of reasons. And some of those reasons may leave that patient still able to receive LIT. So perhaps it's a deep or difficult to access lesion, something that's in the thalamus or the internal capsule or something around there. Maybe that person's elderly and you're a little bit gun shy for doing a big craniotomy on them. Maybe they have a slightly lower performance status and you're gun shy with craniotomy. Or a lot of us know this, of course, there will be patients that come from another hospital where they quote unquote got it all and there's clearly some residual tumor there. Are you going to open that patient back up to get that residual tumor? Or might there be some other options like LIT for cleaning up after that? The key point here is that if you can biopsy safely, i.e. if you can get a needle down into that lesion, you often are going to be able to also get a laser into that lesion to offer some cytoreduction. So how prevalent in your practice is a situation where you're only offering a biopsy where that lesion also may still be amenable to laser treatment? So here's an example in GBM of a case where I'd be a little bit less excited about an open craniotomy. There's not a very kind of long or wide trajectory, safe trajectory that you can get into this. It's deep, it's in areas that are fairly eloquent. But you can see, even with the DTI images here, that there is a little bit of a window that safely you can get a biopsy needle into a lesion like this. It's not that large. It's very easily treated with the laser to really no detriment from a neurological perspective. So this is an instance of a deeper lesion where offering the laser offers an advantage, I think, over doing a large craniotomy. And there's also deep low-grade gliomas, and this is I think hopefully a lot of you can see this little T2 lesion, maybe my arrow is showing up. in the thalamus here. This was a 13-year-old kid that had symptoms from this. And obviously we need a biopsy, and we also need to treat this if possible. And offering cytoreduction is fantastic, but this is a tough spot for a destructive craniotomy to get all the way down there and get that out. But it was a great spot to essentially swap out a biopsy needle for a laser and offer him some cytoreduction. He was a snarky kid, really a funny kid, woke up a little bit paretic, which made me really nervous. But then a day later was fine. And then he sent me this video afterwards, which is always good for a laugh after the surgery.
Dr. Fetchy, everything is working fine. Right hand still works very well. The left hand is doing perfect. This one won't go down. What? What? I don't get this. Thank you so much, and a Merry Christmas.
So he's doing great now. This is years ago. He's now in college at Brown, and he's doing a joint undergraduate in medical. So he's doing fantastically. Comes to my lab meetings every now and then. Great kid, and obviously doing great. This was, of course, years ago. So key points for newly diagnosed gliomas. If you're only offering biopsy, which is some percentage of patients, then the Stroop protocol survival benefit is obviated. If you can safely biopsy, you can frequently offer cytoreduction via LIT, which is the goal of surgery. So who may not get maximal resection? Biopsy or partial resection only. It might be difficult to access lesions, like some of the ones we just showed you. It might be elderly patients. It might be patients with a low performance status. So can you consider LIT in those folks? So that's newly diagnosed tumors, but what about recurrent tumors? Well, here's a hint. There really isn't a standard of care here. So there isn't a kind of typical decision-making tree we follow. This is a friend of mine made this. This is a quote-unquote pragmatic algorithm to organize the options in recurrent GBM. This is a pragmatic algorithm. I think it looks like a headache, but the simple fact is that there's clearly an area where you can start talking about other types of therapies, and I think LIT is one to consider. So who doesn't get surgery in recurrent GBM? Turns out a lot of people, because there's only about a 14% reoperation rate nationally. And it's always a balance of the goals of surgery versus the risks. I think most people will say that the surgical therapeutic window is narrower here because there's an increased risk for redo operations. For all the things that are listed here, those surgeries can be no fun. But I do think that most people will agree that there's a benefit to continued cytoreduction in these folks if you can do it safely. And there's also a benefit to getting tissue for use in things like trials. If we look retrospectively at data from clinical trials, they often show that there are people who had complete resections or complete cytoreduction did better than those who did not. Of course, these are all skewed by the bias of indication. It's retrospective data. But the fact is that I think, again, most people feel like there's a benefit to continued cytoreduction if it can be done safely. And again, 100% of GBMs recur, so there's plenty of opportunity to look at a lesion here and decide whether or not the laser might be an appropriate or amenable procedure. Key points, 100% of them recur. There's no standard of care for these patients. Surgery is often no fun. Many of these patients will get biopsied to establish recurrence and obtain tissue for testing. Again, if you can safely biopsy someone, the question is, can you also offer them some cytoreduction via LIT? Many fear the risks of a large surgery in this population. This is a minimally invasive procedure that is very, very well tolerated, even by patients that are a bit fragile. All right, that covers glioma, and on to the bulk of this, which is metastatic disease. Standard of care for metastatic disease, I think we're all quite familiar. Everyone is going to get radiation of some form. Most typically, that's going to be stereotactic radiosurgery these days, which is appropriate. Some people will get resection. So some newly diagnosed patients will get a resection before or after radiation, depending on how your institution does it most commonly. Who are the folks that get resected brain mets? Well, besides having to be stable for surgery, generally we're offering surgery for large symptomatic lesions. And the reason we're doing that is twofold. Number one, to reduce the symptoms of that lesion and the mass effect. And the second thing is to also reduce the cell burden so that things like radiation will work better. And people who have smaller lesions that aren't symptomatic are typically just getting stereotactic radiosurgery, which of course is an extremely effective regimen compared to like EBRT for GBM, which is obviously quite a bit less effective. And SRS has, sometimes 85 to 90% local control rates. And so there's a very, very good treatment option for people that have smaller, less symptomatic lesions. So if people are not getting resection, they're typically just getting stereotactic radiosurgery, which is the standard of care. So what we found typically is that really lit for newly diagnosed Mets, it's really not the best place for this technology. Any patient that has a surgically appropriate Met usually is having a large lesion with mass effect, and that's not something you're usually going to treat with lit. If they're large or symptomatic enough to warrant surgery, then you really need to get the lesion out. And if the lesions are surgically inappropriate, then they're usually being able to be safely and easily and effectively treated with SRS with good control rates. So this, again, it just really isn't the best use for the laser. However, that being said, radiographically progressive metastatic disease, radiation necrosis, recurrent metastatic disease, this is really a boon. And I have to say, this is the largest bulk of my practice with the laser. So I started with radiation necrosis. This was kind of low-hanging fruit for us. About 10 to 15% of SRS-treated lesions will undergo radiation necrosis. Usually it's more than 6 months after treatment. The treatment options, as you see all these things here, with the exception of surgical resection, are mostly anti-inflammatory in nature. I have had some success explaining to my patients in North Carolina that this is kind of like having a rash in the brain, and you can try things like steroids, but that may not always work, and so then sometimes you have to do something else. My radiation oncologists hate that, but it does seem to work with patients. It's often indistinguishable on imaging from recurrence or progression. I know lots of people have different things that they do, but the fact of the matter is that nothing is 100% sensitive or specific. And the beauty of the laser is that no matter what your biopsy result here, radiation necrosis or progressive disease, lit treats both effectively. I'm going to go through some of that with you now. So, common misnomers. Rhode Island is not an island. Long Island is, for the record. Acoustic neuromas are neither acoustic nor neuroma. They are vestibular schwannomas. And radiation necrosis is not just dead tissue. It's an active inflammatory physiologic process. So people will often ask, well, why would you treat dead tissue with a laser? Well, it's not just dead tissue. There's a contrast enhancing leading edge that's inflammatory in nature. Why does the laser work against this? We don't 100% know. I will tell you that my theory here is you get these small leaky vessels that I think get ablated by the laser, and that prevents the leakage of all these inflammatory things into the environment. But regardless of whether I'm right or wrong about that, what I can tell you very, very assuredly is that it absolutely does work, and I'll show you some data soon. So what are some typical algorithms for radiographically progressive metastatic disease? After these things recur, there's a lot of different ways people have addressed this typically. Unfortunately, some will just assume that it's a treatment failure and re-SRS. That's not great. If that's radiation necrosis, this will be harmful. The analogy I use is that if someone gets stung by a wasp, the cure for that is never to have another wasp come and sting you in the same place. And so, of course, more radiation to radiation necrosis will be bad. And unfortunately, some of those patients, when that happens, then do poorly and get put on hospice when really there's a lot better way to treat them. Some people will use steroids to diagnose, and if the steroids work, then we just assume it was radiation necrosis. That's fine. But I think that's getting to be a little bit antiquated. Early biopsy is starting to get more and more favored, I feel, for a couple of reasons. Number one, because we do so much better with metastatic disease now than we used to, that there's lots of treatments for recurrent metastatic disease, and your medical oncologist often wants to know whether their treatments are failing intracranially or not. And if you get that biopsy result that shows there's recurrent disease, there may be a change to the systemic regimen made by the medical oncologist. They're going to want that information. And now, because of the advent of the laser, we have started to really move towards earlier and earlier biopsy, knowing that we have a very minimally invasive treatment for these folks, no matter what the biopsy shows. Okay, so that was long-winded, but the key points here: lit addresses either of these diagnoses effectively. It's minimally invasive alternative to what can otherwise be annoying surgeries. It does give you tissue. It permits concomitant biopsy, and that is very helpful to the oncologist. It permits appropriate subsequent treatment. If there is progressive disease, we come back in with another round of SRS, and if it's radiation necrosis, then lit is usually enough on its own. And we'll start to talk about some of those decision algorithms soon. Another thing that I'll also show you is that lit also really gets people off of steroids more quickly than simply treating them with steroids for prolonged periods of time for their radiation necrosis. We all know the side effects of steroids. We know that patients typically hate them. But there's another thing to think about nowadays, which is that in general, most of these patients with metastatic disease are going to be on some form of immunotherapy, which is a standard of care now. And those steroids, if they're on those for prolonged periods of time, are going to counteract the efficacy there. Lit also, I think, can be used instead of bevacizumab, which also has a wealth of limitations. Some people use Bev quite liberally in radiation necrosis for Mets. Some people use it as a salvage therapy. We're in that latter group, but either way, Bev has issues with wound healing. It precludes surgery for 4 to 6 weeks. There's risks of DVT, PE, bleeding. It's expensive. And oftentimes when you stop it, everything just comes roaring back anyway. So how frequent is radiation necrosis? Because some people say they never see it. It seems hard to imagine. But this was a paper we put out years ago. And this was just when we had done about 35 biopsies for radiographically aggressive metastases. At this point, with all the lit that we've done more like 250 of these. And so we're actually looking to kind of update this paper, so to speak. And what we found was interesting. If people have radiographic progression inside of 9 months after SRS, in other words, if they kind of progress quickly, it's about a 50-50 endeavor as far as whether the biopsy shows pure radiation necrosis or shows some recurrent disease. But once you get outside of 9 months, in other words, when you're further out, if that's the first time you see radiographic progression, overwhelmingly that's radiation necrosis, which I think those numbers may or may not hold true after hundreds of patients. But what I will tell you is that the simple fact is that if people are going to fail, they fail early. And the further out you are from radiation, the more likely it is to be radiation necrosis. And overall, after doing hundreds and hundreds of patients' biopsies with lit cases, overall, it's very consistent. We see about 60 to 70% of biopsies for radiographic progression show pure radiation necrosis. So it is quite frequent and quite prevalent. This was a paper we put out last year that looked at time to steroid independence after lit. And we found absolutely that we get patients off of steroids much more quickly. It's not close as far as lit versus medical management. And then the other interesting thing is that we did see trends towards better freedom from local progression with lit compared to medical therapy, as well as trends towards better overall survival. One question that we really wanted to address, and I touched on this earlier, is what should you do if your biopsy shows that there's a recurrent disease and you use lit? Should you come back in with more radiotherapy? And we had a lot of other institutions that we combined our data with here, and some of those institutions were not routinely offering repeat SRS. They were using lit kind of instead of that. And some institutions, including our own, we were using lit as an alternative to surgery, which again is what I harp on. And so if we had offered resection for a recurrent metastatic disease, we would always offer repeat SRS provided they had room to be treated. And so we were using repeat SRS after lit for recurrent disease. And we all got together because we wanted to know what we thought was the right answer here. So this is data that was pooled from Duke, Cleveland Clinic, WashU, Yale, and Minnesota. And we looked at all of our patients and combined that together and tried to figure out what the right answer here was. So everybody here had to have biopsy-proven recurrence. And if you look at the data, it's actually quite striking. Now, granted, this is all limited by the fact that it's retrospective data. But what you can see is that when you combine lit plus SRS for recurrent metastatic disease, the median freedom from local progression goes out to about 30 months, compared to less than a year for either of those treatments arms alone. That was a substantial improvement in FFLP. And likewise, we saw that there was a significant extension in overall survival of more than a year for recurrent metastatic disease. So again, that's retrospective data, and I'll talk to you a little bit about some prospective data we're trying to accumulate there. But some key points for radiographically progressive metastatic disease. Lit permits early diagnosis. It can address either biopsy result effectively. It's less challenging than open surgery for radiated lesions and has tiny incisions, so benefits for wound healing. And it can be a good alternative to prolonged steroid treatment or to Bev for radiation necrosis and can get people off of steroids more quickly. So again, I talked about the fact this is retrospective data. Prospective is really the way to go here if you want to answer this question properly. We have a large trial that is now about to open up at 8 more institutions. It's been piloted at Duke and Wake Forest, and it's been open for a year. We've enrolled already about 20 to 25 patients. And so this is the study design. Patients with radiographic progression get a stereotactic biopsy, which is kind of standard for us. We do this relatively early in the process now. The frozen diagnosis will either be radiation necrosis or progressive disease. And so right there, based on that frozen in the operating room, they get assigned to one of 2 arms and randomized. Component 1, if it's radiation necrosis, They're randomized right there in the OR to either medical therapy with steroids or to lit. If the frozen shows progressive disease, then they get lit either way, and they are randomized postoperatively to either observation or to postoperative SRS immediately. Important to note, there's no placebo here, and patients who fail the more conservative arms can, of course, then be treated with whatever is appropriate, including the other treatment modalities on the study. Again, we've had really no problem enrolling to this study, and hopefully we'll have some interim analyses in the next year or so. The objectives here are pretty simple, and I don't think we really need to go over all that, but if you're interested in participating, please feel free to email me. Monteris is sponsoring the study, and they are ultimately who makes the decisions for who enrolls in this, who gets the trial, so to speak, but please feel free to email me if interested. So all told, what is the lit fit, which I think is a fun term. So first off, lit fits well as a tool for surgical site reduction in instances where the therapeutic window for open resection is narrower, i.e. that risk versus benefit window, but there is still a desire for site reduction. And if you can biopsy, you can often safely lit, barring procedural limitations. So who are the patients that it's going to be? Let's go down by category. In newly diagnosed GBM patients, it's mostly going to be deep or difficult to access lesions or fragile or elderly patients, people who might otherwise only get a biopsy or subtotal resection. Recurrent GBM, really, this is a great area. So all lesions, as long as they're amenable to lit, might be a good place for the laser. Newly diagnosed metastatic disease, I think this is the toughest justification, and I think most people should get SRS rather if they're not getting surgery. And patients with recurrent mets and radiation necrosis, however, this is a great use for the laser, barring the limitations of the procedure and having a lesion that's amenable to the procedure. And this is really probably 80% of my practice with the laser, frankly. So in summary, recurrent lesions, radiation necrosis, and deep or difficult to access lesions that are less than 3 to 4 centimeters in size. For those of you, this is always my shout out to the radiation oncologist. If you're going to build a successful lit program, just remember that the radiation oncologist sees 100% of new brain mets, treats 100% of recurrences, manages 100% of radiation necrosis, and incidentally also sees nearly 100% of the GBMs at your institution. Just saying. So you should really probably make friends with this person and talk to them, because you're not going to build a successful program unless you have them on board. Also important to know, this is now part of the NCCN guidelines for recurrent GBM, as well as radiographically progressive metastatic disease. And there are position statements from the joint CNS and ANS tumor sections supportive of this in those instances. Perhaps not surprisingly, I'm an author on that. And another one or two little quick things, and we'll wrap up. It's important to note also that there are pretty standard radiographic changes that occur after the laser. You need to know this. A month or two after, you'll see a slight enlargement of the lesion with a thin eggshell of enhancement, and then that lesion will contract down to a gliotic scar over time. This was the first patient ever treated at Duke. He was an 85-year-old with recurrent metastatic disease. You can see more rapid resolution. It doesn't have to take a year. Sometimes it happens within months, but I think that the longer course is more typical. We have now found that we can kind of predict things by actually creating an object out of just the enhancement. So if you just measure the volume of the enhancement, not the volume of enhancing disease, but just the volume of enhancement, you see that typically by about 4 to 9 months in patients who successfully responded, you're seeing a decline in the volume of enhancement, whereas the patients that have failed tend to see a continued increase. We are doing some interesting things, building nanotechnologies that can be used to expand laser coverage, as well as create specificity at tumor borders. We're working with our engineers. This was a paper we just put out in Clinical Cancer Research. The cool thing about these things is that when infused, they collect selectively within tumor. What I'll leave you with here is that we have now had Monteris and Brainlab donate systems to NC State's Veterinary College. This is one of the top vet schools in the country, and I worked for a year with the veterinary neurosurgeon there to develop the capacity to do stereotactic neurosurgery in dogs, as well as to do the laser. It's important that you recognize that dogs get gliomas, and and it's mostly the brachycephalic breeds, so boxers and bulldogs. 20% of boxers will get a glioma in their lifetime, which is staggering. So we have now devised the capacity to do lit in dogs. It's the only veterinary institution in the world that does that. This was one of our first happy customers the day after getting lit for his glioma, and did great. So this is a very, very safe and easy to do procedure in these dogs. It did take us a little while to figure it out. But we can now also use these dogs as a preclinical model for things like the nanotechnologies to try to improve this technology moving forward. And it's certainly been really kind of fun, interesting, and cool to develop this in dogs. Really had a blast doing it. So welcome to the 21st century and to some of the newer technologies that are out there in neurosurgery. Thank you for your attention. This is my lab, which doesn't have a lot to do with this, but thank you to them as well. And happy to answer any questions.
Thank you so much, Dr. Fecci. That was just a great talk and super entertaining for kicking us off for at least this early hour here in the Midwest. There was one question actually from Dr. Max Krukoff, who I know you know well at MCW.
Yeah.
He also commented on how great your talk was. I echo those sentiments. He said one question for radionecrosis cases that fail lit, and he said, i.e. continue to progress. Why do you think they fail? And then can you also comment on the current role, if any, for whole brain in metastatic or recurrence of disease in this day and age?
Yeah, so great question. We have found, just to put things in perspective, we have found that lit has about a 95% effectiveness rate for radiation necrosis. And I will say that a good number of times that people fail, when we biopsy them, we find that actually a good number of those failures are actually ultimately turn out to be true recurrent disease. And so that, you know, may have been a sampling error on the biopsy, or maybe the disease came back subsequently. So I think some percentage of those failures are because there's actually disease in there, and you may not have offered more radiation after you initially lasered them, which we know does help to control the disease. But for the true failures where it's actually where it's actual progression, I don't know. I really don't know. And you know, there's a variety of things that could be either you subtotally covered it, or it's a rip-roaring inflammatory response. I have noticed that some of those people that failed too typically were more likely to be on immunotherapy. So sometimes it's just that there's a much larger or different style or mode of inflammatory response. But the short answer is I don't have a great answer for that. It doesn't happen frequently, but you're right. It's an interesting question. As for the role of whole brain, I think less and less. You know, obviously there are certain diagnoses that we typically use whole brain for, like small cell lung cancer, but even that is starting to go by the wayside. Increasingly, there's literature out there where people are trying SRS instead and having good results. I think, you know, innumerable metastases or large volume of disease, where the volume is greater than a certain number of cc's, or you don't feel safe treating with SRS, you know, that is going to be the kind of remaining area. Leptomeningeal disease as well. That's really going to diffuse leptomeningeal disease, not focal pachymeningeal disease. I want to make that distinction. Diffuse leptomeningeal disease, widely innumerable brain metastatic disease, and large volumes of metastasis, and potentially certain diagnoses like small cell. I think those are really the only remaining appropriate areas for whole brain. Obviously, the radiation oncologists are the people that should comment on this more than me. But I think at least I don't think that I'm stepping on my own radiation oncologist toes. I think most of them would agree with that sentiment. So.
No, and I agree with you 100%. That was great. Thank you so much for answering that. For those people who are online, please feel free to continue to utilize the QA box. We'll have Dr. Fecci joining the first panel session after we're done with our other speakers this morning.
It's great pleasure to introduce our next speaker, Dr. Peter Gersten. He's a Peter E. Specht Professor of Neurosurgery at University of Pittsburgh. Dr. Gersten specializes in spine surgery with special interest in neuromodulation and stereotactic radiosurgery for spinal metastases. And today he'll be discussing radiosurgery as part of a multimodality treatment for spine mets. And welcome, Dr. Gersten.
Thank you. Can you hear me okay?
Yeah.
Okay, excellent. Well, first of all, thank you so much for inviting me to participate in this wonderful program. And it's always interesting, especially for the trainees in the audience, when we think of CNS metastases, we immediately think of brain metastases, but we have to remember that for every brain metastases, there's a spinal metastases that are equal, and these are equally as challenging to care for. I just want to say for those of you who don't know Pittsburgh, I'm sitting here in Pittsburgh, Pennsylvania. We are known as the city of bridges. We're very proud that we have more bridges than any other city in the world, including Venice, and hopefully you'll be able to visit us one day. The issue of spinal metastases is not a new one, and I just want to emphasize that it's a huge problem. As I stated before, for all of the issues of CNS metastases and the challenges of caring for these patients with CNS metastases, we also have spinal metastases, nearly 200,000 new cases per year in the United States. And we all know that these metastases can be disabling, cause loss of mobility, fractures, paralysis, and there's a wide variety of new treatment modalities. So taking a step back, once again, to emphasize for those of us who have cared for these patients for a long time, it was really back in 2005, that is nearly ancient history now as far as medicine is concerned, but nearly 20 years ago, the Patchell trial for the spine was published, and it really changed everything, because all of a sudden, prior to this, these patients were treated maybe with short courses of radiotherapy, steroids, pain medicine, but rarely were they referred to surgeons. And in 2005, all of a sudden, radiation oncologists and neurosurgeons found, and medical oncologists as well, the patient should be referred back to surgery again for their care. And so neurosurgeons became very excited, because we were developing rods and screws that we were using for trauma and degenerative disorders, and we applied those to oncology. And we had the ability to perform these very big surgeries, but we quickly learned at a high price that these patients are very debilitated from their underlying disease, from their systemic therapies, from their prior radiation treatments. And this is an article that I wrote early on relatively early on in my career with members from Sloan Kettering, where we started to compare notes on what are the best ways to operate on these patients, but what other treatment modalities are there? And that's where we started to become more and more interested in radiosurgery. So I'm not going to define spine radiosurgery or any radiosurgery for this audience who's very comfortable with these technology, but we're slightly different than intracranial radiosurgery, where we're usually talking about single fraction treatments. We're talking about single fraction 14 to 24 gray or hypofractionated treatment. But by and large, we're talking about short courses of very large doses of radiation that apply a cytotoxic, or quote ablative is the newer term, to tumor that spares normal tissue tolerance. And the principal applications of this to the spine are very similar to for intracranial CNS metastases, that primary treatment for radioresistant tumors to avoid fractionated radiotherapy or surgery, reirradiation following conventional external beam radiotherapy, as a postoperative adjuvant, and then as a neoadjuvant therapy for primary tumors. So the rest of the talk is really going to show how we have integrated in 2023 this new technology, or no longer new technology, of spine radiosurgery into the care of these patients. Just a background about Pittsburgh and how I became started in radiosurgery. We have a long history of intracranial radiosurgery with the Gamma knife and then Linac-based intracranial or cranial radiosurgery therapies, but we became very interested in spine radiosurgery because of our close collaboration between neurosurgery and radiation oncology, and a very large number of patients as a large cancer institute. And our first case was back in 2001. And not only is this a large experience, but we can really focus on late toxicities and getting a better idea of how best to integrate radiosurgery into the care of spinal metastases. So the indications for spine radiosurgery is really an evolution in progress. As I stated before, we're trying to define which patients are best candidates for as a primary treatment modality for medically inoperable patients. As we stated before, many of these patients are poor candidates for open surgery. Many of these patients have had prior conventional fractionated radiation as an adjunct to surgery, and for lesions that are simply not amenable to open surgery. And once again, for the residents and the younger faculty in the audience, we started, as we always do, as you always do, you start small. We started focusing on radiosurgery for different types of metastases, because just like in the brain, we know that patients with lung metastases in the spine are very different than melanoma and renal cell and prostate cancer. These are all different types of patients. But fast forward to today, where we know we have a very good understanding of, for instance, with melanoma tumors, how we can employ radiosurgery into the multimodality treatment for these patients. So taking a step back, just one more time, back to 2005, it was really this paper from Georgetown, and to give credit to these clinicians, where they really were looking at radiosurgery for as a treatment modality. And what they found and published was that radiosurgery was very effective for controlling pain and improving quality of life. What's a big distinction between intracranial or brain metastases and spinal metastases is that pain is the primary chief complaint and symptom for which we are caring for these patients. And what they found was that there was significant and durable pain relief. So fast forward, many centers, we worked together around the country, around the world, where we pooled our data and looked at multi-institutional data analysis. And what we found is that local tumor control up to 2 years was 84%, and the development of toxicities, including compression fractures, was relatively low. So we became very excited. And not only did we find that long-term pain control was very, very effective, but pain improvement occurred sooner and lasted longer than compared to conventional external beam radiation therapy. So what is the, I just have to move that so I can continue. So where do we stand with radiosurgery after conventional external beam radiotherapy? Because still in the United States, the vast majority of patients are undergoing conventional fractionated radiotherapy for spinal metastases for pain that are relatively asymptomatic. And the workhorse of the failures is the default is radiosurgery. Although interestingly, listening to the earlier speaker about LIT, where LIT is having a important and emerging role in the treatment of spinal metastases, just like intracranial metastases. But we found that there were, even after conventional fractionated therapy, we had excellent long-term control rates, and we also had very low rates of toxicity. And looking a little closer, where we found one more time that at last follow-up, nearly half of patients did not report any pain. So we became very good at treating these patients for their pain complaints, preventing future needs for surgery for these patients. So we became very excited with this technology. So where do we stand in 2023 with spine radiosurgery? What are the current recommendations? It's really, what we know is that it's not only safe and effective and durable symptomatic response independent of histology, but where we are focusing our treatment is for oligometastatic disease as well as radioresistant histologies, where that is the default for upfront radiosurgery. A word about late toxicity, because that was important, because many of these patients are now living, especially with breast cancer, prostate cancer, even melanoma, renal cell carcinoma, they are living a long time. So we looked in our own series at 5 and 10-year rates of late toxicity, and what we found is that the incidence of late toxicity is very, very low. So we are good at delivering large doses to the tumor volume and also limiting the doses to adjacent normal structures. And even others have published about the experience of salvage radiosurgery after prior radiosurgery, similar to the earlier talk about performing radiosurgery after prior radiosurgery for failures. There are several centers that have published where local control rates can be achieved as high as 70%. And then, interesting, combining it with our last talk about combining radiosurgery with systemic therapy, especially with these tyrosine kinase inhibitors. This was a nice work from the Cleveland Clinic where they showed that at 12 months, the cumulative incidence of local failure was only 4%. And we can find, can pain outcome be improved even further when we combine with systemic therapies? A word about single versus multiple fraction for spine radiosurgery. There's really no clear advantage in 2023 that we know between 1 versus 3 to 5 fractions. I'll show you in a moment the data regarding from the prospective trials. But as it stands right now, our default is to use a single fraction for patient convenience if we can get away with it. If we feel that the patient would benefit from 2 to 3 fractions, then, and it's a safer for the toxicity to the spinal cord, then we will fractionate in 2 to 3 fractions. But there's still no agreed upon feeling whether single versus multiple fractions is one or the other or necessarily superior. Now, moving on to class 1 evidence, because as we started with our single center experiences and then combined them, but we wanted the need is always for class 1 evidence. And the RTOG experience, which was published recently, Sam Rue from Stony Brook really led this, and I was involved as well. It was 353 randomized patients, 1 to 3 tumors throughout the spine, and it was randomized for conventional fraction radiotherapy of 8 gray versus 16 or 18 gray. And pain, the primary endpoint was pain at 3 months. In the end, the findings that there was no difference in quality of life and pain at 3 months. But the takeaway message was this: importantly, there were no complications, or complications were exceedingly rare at 24 months. In my personal opinion, it's because our doses were too low. That a 16 gray is not sufficient to achieve a significant difference in pain outcome to an 8 gray fraction, a single fraction treatment. But it also showed that excellent tumor control rates as far as 24 months, and the benefits of using radiosurgery in the setting of oligometastases. The other important paper was Arjun Segal's paper that was performed in Lancet Oncology in 2021 that I feel, I'm not a radiation oncologist, but I sense that this is the prescription algorithm that many radiation oncologists around the country and around the world have adopted, of using 24 gray in 2 fractions. The primary endpoint was similar, and they found a significant difference, that the spine radiosurgery was very, very safe. Higher doses, I feel, are necessary to achieve a better pain outcome. There's a excellent long-term pain control and excellent long-term tumor control in these patients. And once again, radiosurgery for oligometastatic disease is very, very beneficial. Just now switching hats from my radiation oncology hat to my neurosurgical hat, how can we combine other minimally invasive procedures or open procedures? to integrate, to really take care of these patients in a better fashion than being siloed to either or fractionated radiotherapy or major surgery, like was done 30 years ago in the 1990s. But how can we integrate all of these technologies? And most of these patients we're looking at, we're focusing on mechanical pain control and tumor control. So we combine both of these very, very easily and effectively, and that's percutaneous fracture reduction, or kyphoplasty, or vertebral cement augmentation. It has a couple of terms, but really we're talking about taking patients where we can focus, place cement, get a biopsy if necessary, and then follow up with radiosurgery. And now this has become so important part of the treatment algorithm that I think most radiation oncologists are very comfortable with referring these patients immediately to their neurosurgery colleagues or orthopedic spine surgery colleagues for these procedures. And then we can take it a step further with more minimally invasive treatments for spinal metastases, where we can, with small incisions similar to LIT, but what we are doing, where we are actually removing tumor, placing cement, and then following it up with radiosurgery. So now radiosurgery for the neurosurgeon has really become a surgical tool in the armamentarium. So fast forward again now to today, 2023, if you have a patient with mechanical back pain, with renal cell carcinoma, who's otherwise pretty active in the past, we might be thinking about doing major open surgery. We know that en-bloc resections have associated with a great deal of morbidity and not necessarily a great long-term control of their tumor. And they would still need fractionated radiotherapy or some sort of radiation following this. So now what we can do is we can perform we can perform cement augmentation, then follow it up with 22 grain single fraction treated with VMAT. This is a very short single treatment, as that performed as all done as an outpatient, and 10 years later the patient can retire down to North Carolina to play golf. So we know in 2023 what can safely be treated with radiosurgery and that what cannot. The Bilski criteria that it was initially developed for neurosurgeons and by mostly neurosurgeons, but now we understand how important that is for radiosurgery, that we know that all of these in 2023, these Bilski 0 through 2, these can all be treated with radiation or radiosurgery, and only a minority of patients actually require open surgical decompression. So that brings the concept of separation surgery, where what we can do with these patients, we can remove the tumor from the critical structures, which is usually the spinal cord, but not in all cases, but usually the spinal cord, and develop a plane between and some distance of several millimeters between the spinal cord and the tumor, and then follow this up with radiation. So all of a sudden, radiosurgery becomes part of the surgical approach because we start with a minimally invasive procedure. We can place screws and stabilize if necessary. We can perform separation surgery, and then we can follow this up with radiosurgery. And there have been many studies that have shown that radiosurgery for these patients is much better than conventional radiation. There are higher rates of fusion. There's less dose to the fascia and the skin, so it improves wound healing and lower rates of hardware failure. Then finally, moving on to the issue of implants, that a third of these patients have some sort of implants. We know that because these patients often present either with stabilization, requiring stabilization, or they require percutaneous cement augmentation. And we know that now it is very safe and it's very easy to treat these patients. So the major paradigm shift take-home message is that we have now changed the approach to patients with oligometastatic spine disease, just like the debate 20 years ago about whole brain radiotherapy versus radiosurgery for intracranial brain metastases. Now the same conclusion can be stated regarding oligometastatic disease for the spine. Where are we heading tomorrow? Well, it's the concept of perhaps radiosurgical decompression. We know we saw beautiful pictures from whether it's radiosurgery or lit for CNS lesions, where we can shrink those lesions, actually physically shrink those lesions. We can now do the same in the spine, where we can take patients who are not candidates for open surgery. We can treat them very, very effectively and then obviate the need for any open surgery. So just an example of a patient who a T10 lung metastasis, had a prior posterior decompression. Unfortunately, they were Coumadin dependent for a lower extremity DVT. And so what we can do now is 27 gray and 3 fractions, and we can actually shrink the tumor away. Then the concept of the SIN score is the Spine Oncology Study Group. We developed a stabilization score or an instability score to allow medical oncologists, neurosurgeons, radiation oncologists. So we're all talking about the same thing, so that we know which patients can avoid any open surgery, or do they even need something like vertebral augmentation. So now that they're in NCCN guidelines, we're including radiosurgery or cement augmentation, other minimally invasive procedures for patients with metastatic spinal tumors. Finally, a word about spinal cord tolerance and complications, but really spinal cord tolerance, because when we started 20 years ago, the big unknown was what were safe doses to the spinal cord for treating these patients, and were we simply going to hurt a lot of patients by giving them such high doses of radiation. But one more time, fortunately, fast forward in 2023, our radiation oncology colleagues feel very comfortable with a variety of large studies where we know now, this was back in 2012, this was with Arjun Segala, who's really been the leader of developing these algorithms and of these safe treatment recommendations. But what we know is that single fraction treatment or dose of less than 12 gray to the spinal cord is very, very safe. So that the current recommendations, this was his follow-up from 2019 that I'm sure all of the radiation oncologists in the audience are very familiar with, that depending upon 1, 2, or 3 fractions, we can treat these lesions in a very, very safe manner. We do not need to worry that the spinal cord is the limiting factor to treating these patients. So I just want to end with, in a similar fashion to the way that radiosurgery is an essential part of the treatment paradigm for intracranial tumors. There is no center in the world who treats intracranial metastases and has a specialty with intracranial metastases who does not employ radiosurgery. The same has to be true in the spine. Radiosurgery is an essential part of the multimodality treatment for spine tumors. So the take-home message is that now there's high quality evidence of the low rate of late complications. There's high quality evidence for appropriate target volume delineation and safe dose prescriptions to the GTV and the organs at risk. And there's a great deal of knowledge regarding the spinal cord tolerance to radiosurgery. GTVs should be kept around 24 gray for a single fraction, are very, very effective. And we know that spinal cord tolerance is higher than we initially thought. So I want to thank you very much, and I'm open to any questions.
That was just great, Dr. Kirsten. Thank you so much for joining us. I don't have any questions in the Q&A. And for the audience's knowledge, Dr. Gerson is actually going to be traveling to his father's 96th birthday. So happy birthday to him, Dr. Gerson. Thank you so much for your time today, and we really appreciate you joining us.
Okay, thank you, everyone. Thank you so much for having me.
Sorry, I just have a quick
Yeah.
question. You know how you talked about the dose to the spinal cord and its tolerable dosing. In that context, how does the separation surgery fits in with the dosing to the spinal cord versus when you would use separation surgery?
That's an excellent question. So the bottom line is that if there is spinal cord actually compressing, I'm sorry, if there is tumor actually compressing the spinal cord, we only have, we meaning a neurosurgeon and a radiation oncologist, there are only two options. Number one is to underdose the tumor, and number two is to overdose the spinal cord. So if there is a compression of the spinal cord and you want to achieve a 18 gray to the margin of the tumor, you're going to overdose the spinal cord. We can fractionate it, as I showed you, but I still believe that for long lengths of the spinal cord, if it's possible, the best is to perform some form of separation surgery. It's the safest portion because we know sometimes the tumors swell as well. But I would tell you the big difference is that in today versus 20 years ago is that the type of surgery has changed. So we can perform very small, minimally invasive decompression separation surgeries rather than large surgeries, outpatient procedures, and then follow it up with radiosurgery. So this type of surgery that we perform has been changed because of the ability to perform radiosurgery afterwards.
Dr. Gerson, Zach Morris, Wisconsin, quick question. I'm curious if you have seen any literature or had any experience with, as opposed to removing the tumor to create space, is it possible ever to inject a small amount of a spacer? You know, we do this standardly in radiation oncology between like prostate and rectum, but we've been doing a bit of that here with interventional radiology, and a case comes to mind where we recently did that between like a brachial plexus and a tumor. And I know that the spine would be a very tight space, but when we only need a millimeter or two, do you think there's a role for that in the future ever? Or?
Yeah, I'm aware. I'm very well aware of the prostate. It was actually historically, it was a neurosurgeon, John Adler, who encouraged Varian to purchase that material, the company that made the material for the prostate. So we as neurosurgeons have been thinking about this for quite some time. And I'm aware in the brachial plexus, I can't think, I'd have to give that some thought. In the spine, you would have to be moving. My concern is that injecting anything into the spinal canal or cord would in some way make things worse by just compressing the spinal cord.
Yeah.
But certainly in the brachial plexus, that is a very, very reasonable option.
And just one more follow-up question. So does the number of vertebral body involved or the length of the disease determines like the SRS feasibility and dosing?
I believe, yes, there are several studies. One of our radiation oncology residents, we're trying to get him to finish the manuscript for this, but most of the studies have been limited to 3 for a good reason. You know, Sam Rue and others, the RTOG trials, and most trials have been limited to 3 levels, adjacent levels. I think because of the concern of the overall dose to the spinal cord. So as a rule of thumb, I've never seen it performed. That's our top is 3. Maybe probably in Wisconsin, it's very similar. That as a rule of thumb, 3 vertebral body. But one more time, that's in the cervical thoracic spine. In the lumbar spine, when you have the cauda equina, that's very, very different. But quite frankly, it's similar to perhaps the thought of, you know, should we be treating 20 brain metastases with intracranial radiosurgery? At some point, there is a diminishing returns, and probably just a fractionated therapy is a better way to treat those patients, or equally efficacious rather than radiosurgery.
Good. Thank you again, Dr. Gersten.
Okay.
We really appreciate
Okay, thank you so much. Okay, bye.
Bye now. We'll move on with our next speaker. Dr. Jing Li is joining us from Dr. Li. I'm sorry we couldn't do that in person. Dr. Li treats primary metastatic disease to the central nervous system. She's a director of the Gamma Knife Center and co-director of their own brain metastases program at MD Anderson. And today she's going to discuss with us their journey of creating a multidisciplinary patient-centric brain metastases clinic and research program. Dr. Li, thank you so much for joining us today from Houston.
Thank you so much for the invitation. Let me share my, is it this one? Are you able to see?
We are. Thank you.
Okay. How about now?
Perfect.
Okay. Yeah. So it's great to be back to Wisconsin, even though virtually. Madison holds a special place in my heart. Sorry. As that's where I received my education. That's where I met my husband, and that's where my son was born. And I did a postdoc between graduate school and medical school in Dr. Paul Harari's lab. And the photo in the middle is basically I enjoy a Babcock ice cream with my lab mates. So a lot of great memories. So today I'm going to talk about our journey on establishing a multidisciplinary brain mets clinic and research program. Sorry, going the wrong way. And I share with you lessons that we have learned and why it took so long to get to where we are. This audience doesn't really need introduction of brain metastasis. I do want to highlight that despite of groundbreaking progress in CNS penetrating systemic therapy and advancement in radiation and surgery, brain mets remains a devastating diagnosis for many patients due to its impact on patients' cognitive status, neurological status, quality of life, and survival. So neurological death remains a major cause of death for patients with brain metastasis. I also want to emphasize that brain mets patients represent a severely underserved patient population, and that is partially because of the poor prognosis. Many patients are told the disease is terminal, they should just go home and die. And another barrier that we have encountered is because cancer is managed by histology, leading to lack of communication between different medical oncology subspecialties, leading to the lack of collaboration among the multidisciplinary teams. So this is this diagram describes a typical patient's experience after diagnosis of brain metastasis. Oftentimes, patients have to run around the hospital for their uncoordinated visits with different doctors on different dates in different locations. This can cause significant psychological and financial stress for patients and the family. There's also lack of coordination and communication among patients' care teams, and leading to non-optimal care and oftentimes delayed initiation of brain-directed therapy. So I'm going to come back to this timeline a little bit later. So in May 2016, our then president, Dr. DePino, recognized the significant lack of interest and also organized efforts in improving care and research for brain mets patients. He initiated and led the first brain mets retreat at MD Anderson Cancer Center. And with the goals to highlight the urgent critical need and also to really bring interested people together. Quickly after the brain mets retreat, a steering committee was assembled, inclusive of all stakeholders. And this committee developed a mission statement, which is to establish a world-class interdisciplinary brain metastasis clinic that would enable novel clinical research and supports establishment of new standard of care for patients with brain metastasis. As you can clearly see, there are two components to this mission. Number one, to improve patient care, and number two, to conduct research. So coming back to the timeline, as you can see, we didn't open brain mets clinic until 2019. So why did it take so long? For institution with a lot of resources. So what happened was that the institution encountered financial challenges soon after our brain mets retreat, leading to leadership changes. So brain mets was put in the back burner. However, despite of all the ups and downs and the financial uncertainty, because of the awareness that was raised, and also the formation of the core group, the brain mets clinic still made its way to the institution operational priority list. So finally, in 2018, 3 co-directors were named representing neurosurgery, neuroradiation, and radiation oncology. So this new leadership team decided to pursue the clinical component first, as the institution was emerging from the financial challenges, as the clinic itself could most likely be financially mutual, and that request was approved by the institution. So after that, a big brain mets clinical working group was assembled, inclusive of all stakeholders. And this working group worked intensely for about a year on all aspects of establishing the clinic. For example, for staffing model, we identified a team of physicians from each subspecialty and the neuroradiology to staff the clinic. We hired a dedicated APP nurse and PSC. And for physical space of the clinic, we decided to take advantage of newly remodeled Gamma Knife Suite, where we have ample clinical rooms, workroom, and a conference room. And we have to we have to coordinate with the RadOnc team and also the Gamma Knife operation. So for clinical workflow, we decided the high-touch navigation by APP is critical. What does that mean? That means the dedicated brain mets clinic APP will reach out to patients to gather all relevant history. The APP will also obtain pathological specimen, imaging studies, or radiation records, if any. So by the patient, and the APPs will also order imaging studies if patients are due for one. And we also determined that a team huddle before each clinical is critical. And this huddle is run by a neuroradiologist, so attended by the physicians from 3 disciplines. So at this huddle, we review all the cases, and a preliminary recommendation is reached before we start the clinic. I mean, right now, we also have our research team joining this huddle. We also spend a lot of time building the pathways within the electronic medical record system to allow patient referral, scheduling, documentation, and billing. Last but not least, database building. This required a separate weekly meeting with our institution IT and database team. I have to say that turned out to be probably the most challenging part, as we'll touch upon a little bit later. So finally, 3 years after the initial brain mets retreat, we opened the brain mets clinic. And these are some of the photos from the first day of the clinic. As I mentioned, we have medical oncologists, neurosurgeons, neuroradiologists attending the meeting. And the photo on the right is basically a typical team huddle before the clinic. As you know, because of COVID, now those huddles are in Zoom, virtual now. In anticipation of possible problems that we have to address, we opened the referral initially to melanoma patients, but gradually expanded to now all histologies. And we also started to accept direct external referrals a few months after we opened the clinic. So with the establishments of the clinic, patient experience has been substantially improved. So instead of having patient running around hospital, for their uncoordinated visits, now we bring all the doctors to a patient in one location in the same afternoon. Before patients leave the clinic, they know what the next steps will be. And oftentimes their next appointment has been scheduled. So such a patient-centric approach does not come without a price. So for the physicians who staffed a clinic, it means they usually have to add an extra clinic on top of the regular clinic. However, the physicians are committed to doing it for the best interest of the patients. So since the opening of the clinic, we have seen over 1,700 consults. And this photo basically shows some of the physicians from each discipline that staff the Brain Meds clinic. So I'm going to skip this one. Also skip this one. So in summary, we took a patient-centric approach to run our Brain Meds clinic. We have high-touch navigation prior to the consultation. We have a team huddle to reach a preliminary recommendation before the patient is seen. And the patient is seen by 3 doctors at the same time, and they have their next appointment scheduled before leaving the clinic. And our APPs also very good at communicating the recommendations from patient's primary team on the same day after the patient's visit. So the satisfaction rate from patients has been very high, and our retention rate for patients is 100%. Considering that majority of our patients are not from Houston area, in order to keep the clinic running in an optimal condition, we have a weekly meeting for all Brain Meds clinical staff. We also have a weekly leadership meeting. In the summer, we became an independent center with our own budget and organization structures. We also resumed a new retreat. We had one last year, and we had another one this year. So going back to the mission statement, as I mentioned, the other component was research. So as the institution was recovering from our financial challenges, we expanded our focus to research. So in our vision, the Brain Meds Clinic is an ideal platform for conducting clinical trials and translational research. This figure kind of illustrates our vision on how the clinic can help with research and how research can help our understanding of the disease and treatment and improve therapy, ultimately benefit patients seen in the clinic. For example, centered around the clinic with enrichment of Brain Meds patients, we'll be able to conduct clinical trials more efficiently. We'll be able to collect biospecimen for profiling and biomarker studies. We'll be able to use the tissue from the patients to help build preclinical models for screening of new drugs and testing and study mechanistic side of things. And we'll be able to collect imaging and other informatics to build a predictive model. So in the next few slides, I'm going to illustrate each aspect of this. So for clinical trial, so last year we opened our first clinical trial in the Brain Meds clinic. We accrued 3 patients last year and 12 patients this year so far. And we also opened a second clinical trial for all HER2 positive patients, regardless of histology. Those numbers may not look very impressive, but for us, it's very encouraging. We also use the Brain Meds clinic to screen for trials that are not open directly through the Brain Meds clinic, meaning, let's say, a GU Medical Oncology may have a trial, That's run by their own, like geomedical oncology, but they can screen the patients. The research team will screen the patients from brain mets clinic as well. So second point, tissue collection. I know that's a gold mine. Tissue is always a gold mine. We have a very well organized, successful tissue collection program that was spearheaded and developed by the neurosurgery chair, Dr. Fred Lan, along with Dr. Pudavali, our neuro-oncology chair. This is not part of the brain mets program, but will have huge impact on the success of brain mets program. The goal is to store, extract, and profile every neurological patient that underwent surgery at MD Anderson. So the workflow is typically on Friday afternoon, like say at 4 o'clock this afternoon. There's going to be a catalyst meeting. We also call it a tissue auction meeting. All the OR cases from the following week will be presented. And then the people attending the meeting can request tissue for their institution approved and catalyst approved protocols. And then those tissues after the surgery or resection will be dispositioned appropriately. So the tissues will be dispositioned for storage and going to different very specific labs for different studies, PDX model building, sequencing, profiling, immunological studies. And those are all based on institution approved protocols. And we also collect blood and CSF whenever possible, stools if possible. So other than the CNS tumor collection, the institution has other tissue collection programs for extracranial tissue, either primary tumor or extracranial metastasis. So the third aspect for research is preclinical model development and testing. For that, we collaborated with our traction team. I don't remember what traction stands for, but it's kind of like a pharmaceutical company within MD Anderson. So we have worked with them to develop different brain metastasis models, including using animals that are immune competent. Using these models, we're able to test potentially new drugs or combination of different treatments, and also understand how therapy work or not work. So the work from the traction team has led to a few clinical trials in preparation, including combination of studies with immunotherapy and target therapy, sequencing of multimodality treatment, and window of opportunity trial. So one cannot do research without funding, which, as we all know, is a big limiting factor. We're fortunate that last year we received $5 million donation from a grateful patient family. And this family specifically defined how the donation needs to be used. They dictate that, they request the donation to be used for preclinical model development, sample analysis, and also RFA. So I'm very proud to share with you that we just finished our first round of RFA, brain mets related RFA. We received 14 excellent proposals. This doubled, the number of proposals that we had anticipated, and 4 of those proposals were selected with $75,000 per year for 2 years. So the institution matched the patient donation by additional $5 million, and the institution match will be used to help with clinical research, data analysis, and project management. So in summary, in terms of research, we have been able to establish the infrastructure. I forgot to mention that we hired a scientific director who has a PhD in extensive clinical research experience. We have assembled external advisory board as well as internal executive committees who help to guide us in terms of how we determine RFA and also how we to use our funding most appropriately. So the reason that we were able to get so many proposals in the first round RFA, I believe is because of the high visibility that we have been able to raise within the institution for the Brain Mets program. There has been a very strong internal interest. Some challenges that we're still facing, the Brain Mets database. Yeah, this is, we started from the very beginning. It's Friday, 7 a.m. meeting for 6 months to a year. So currently we have a database only with skeleton data. This idea of extracting data from, the electronic medical system sounds fantastic, but it really doesn't work. So I think ultimately we probably have to have hired dedicated people to import data and to also curate the data. And the second challenge is that with the collection of the tissue, profiling can be quite expensive. The institution has a platform that can help with profiling in principle, but when it comes down to doing it, it has been very challenging. So really need funding to profile the tissues we have. And the third unclear aspect is data governance for the clinical database, and also, for example, if we're able to profile the tissues, who have access to the tissues, and the data governance structure is not fully established. Funding were good for a few years, but what's going to happen after that? And one of the things that we thought was a good area that we identified for improvement through the RFA process is that Brain Mets program could be a great place to mentor junior faculty who have interest in studying brain metastasis. Because we were able to fund 4 proposals and we're not able to fund 10 of them, and most of them are from junior faculty. So how can we keep their interest going and help them to do better? Okay, that's all I have. Thank you very much for your attention.
Thank you so much, Dr. Lee. That was such a great talk and inspiring for creating a brain metastases program as well. It was really enjoyable for me to see the timeline that you guys had used to create your brain metastases program. We at the Medical College of Wisconsin, when I was there, we had a similar timeline, actually almost activating to the day that you guys did our own brain metastases program as well. Perhaps for some of the community oncologists that are on the call, can you describe some of the pitfalls that you feel were encountered as you guys were moving forward with creating a brain mets program, and especially with communication across, what's probably 5 disciplines, radiation oncology, medical oncology, neurosurgery, neuro-oncology, and probably palliative care as well. What were some of the challenges that you guys encountered as you moved forward with this program and taking care of those patients in that dedicated multidisciplinary clinic?
Yeah, I have to say the biggest challenge is that each discipline operates differently. And it's very difficult when you are isolated in your own discipline, it's very difficult to see how others operate. And how can we develop a system that works for everyone? So I think what really worked for us is that in the end, we're all willing to be open-minded, or we're willing to listen to each other. And ultimately, I think the driving force is to do what's best for the patient. But I think really just that difference within each discipline, not knowing how others operate and why they operate that way was the biggest challenge, I would say.
And along the same line, how do you manage physician schedule, because you're not going to have a full clinic on day 1. You're going to have one patient, and then, you're trying to manage a neurosurgeon schedule, a medical oncologist schedule for one patient. how do you logistically or realistically do
Yeah.
that?
That's actually a big challenge. So I can share with you how we handle it from each discipline. So for radiation, I was able to, because I make our own like clinical schedule, clinical template. I identified 6 physicians who were staffed clinic, and we have 2 physicians alternate for each of our clinic. And so this kind of built into their regular clinic. So for Radonc, it's very predictable. On Monday, you know who will be there. The 2 will alternate, and that's part of their kind of clinical template. So it's not really like actual clinic. And then, and also it's very predictable. So for neurosurgery, they actually have a roster, and they determine which day who is going to be there. So it is a little bit unpredictable which day who will be there, but they just make sure that for each clinic, someone is there. For them, it's extra clinic. It's not in their regular clinic space, and it's not their own clinic. So they just go there. We typically see 2 to 4 patients in each clinic. I would say for most part, it's a good use of the time because the clinic tend to be very efficient. We tend to room like 3 patients at the same time, and each discipline can go see 1. And since because a preliminary recommendation was made, so it can be efficient, but it's not, you know, we do hear complaints every now and then. The physician felt it was not the most efficient use of the time. So for medical oncology, it was actually the biggest challenge. Because we have to assemble medical oncologists from different disciplines, like, you know, from breast department, from, you know, melanoma department. And oftentimes they feel like they don't have much to offer, but they need to be there. And also another thing is like for neurosurgery and for Radonc, how we count our clinical productivity in the eyes of our chairs is a little bit different from medical oncology. For Radonc, we look at how many patients we treat. For neurosurgery, I think probably how many surgeries you have done, plus a clinical component. But for medical oncologists, you know, their clinical productivity is completely measured by how many patients they see. So if they have to close a clinic, or if they see only 2 to 4 patients in this clinic, is not considered productive. So the medical oncologists have to reconcile that with the chairs. Yeah, so ultimately what we finally able to do, because of the struggle with medical oncologists, now we gave about 5% effort, clinical effort for physicians who staff the brain mets clinic. At least for medical oncologists, I think that works a little better.
And that comes from your center's budget?
Interesting. Very good question. Actually, so that comes from the institution has a STRIDE program at the institution level. So that comes from that. It's a clinical
detail.
It's a clinical operation for now, like staffing the clinic, but the effort is actually counted toward research because that's how the STRIDE program can justify it. So it makes a difference for the Medonc, but for the Radonc, and it doesn't really, it's not a big deal. For neurosurgery, it makes some difference.
So we kind of by default, by time, moved into the panel discussion section. And I know we were unfortunately not able to have Dr. Gerson join as well, but I'm just curious with Dr. Fetchy and then perhaps even Dr. Morris weighing in as well. This is a common problem across all of these institutions with regard to the management of brain metastases. I'm just curious if we could have the other panelists chime in on how those are managed at their own institutions.
Yeah, hi, it's Peter. And I just wanted to repeat the last part of the question, specifically managing the idea of like the clinic, you mean, in the center?
Correct. Yep. Patient flow through the clinic in a multidisciplinary fashion.
Yeah, I was listening to how MD Anderson's done it, and we created our own center about the same timeline. It really started in 17, but our strategic plan was completed in 19. And we do it a little bit differently, and I think it helps solve some of the issues that you guys are talking about, particularly the notion of, how are you going to, if there's one patient in clinic, how are you going to do that, right? That's not a good use of resources and time. The way we've done it is we've made the clinic a little bit more virtual, in the sense that, I have a clinic on a Friday, and we have all of the people that we would like stacked from a radiation oncology, neurosurgery, medical oncology, and palliative care stack all in clinic on the same day. And those patients can weave between their clinic visits all in the same building, but I'm not usurping the rest of my clinic for specifically brain mets. In other words, I may see GBM patients, I may see Chiari malformations, but I'll have a string of Mets patients in clinic that day who then also are seeing rad-onc, med-onc, and palliative care on that same exact day. And that's how we've kind of solved the inefficiency issue there. And we create within the week, we have like a Monday and a Wednesday and a Friday stack. So, Monday it's a different neurosurgery provider that's in clinic, with a different radiation oncology provider and a different medical oncologist and so forth and so on. And that has helped to keep things efficient. We also have navigators. We have a spine Mets navigator and a brain Mets navigator. And those navigators are essentially the face of care to the patients. And it's an NP in both instances, which allows them also to call in meds as need be here and there and make some smaller clinical decisions. And so anytime that patient wants to kind of have a question about care, that's their person that they know that they're going to talk to. And the navigators often will come and see those patients with us in clinic and say hi, but they are also the people ordering scans, making sure that all the appointments are going to be on the same day, things like that. And they also help to screen for clinical trial. And we have an inpatient consult person for the Duke Center for Brain and Spine Metastasis, who can also make sure that patients who are on various services, whether it's internal medicine because it's a newly diagnosed cancer and it's getting worked up, or neurosurgery or medical oncology, throughout the hospital, wherever that patient is, there'll be an inpatient consult, and then that person helps to complete the workup, also helps to make sure we capture them outpatient and follow up, and that they remain in the center and are retained, potentially if it's their first visit to Duke and that inpatient stay is their first time here. It's a face that can say, look, we've got you, and we're going to bring you into the cancer center and set you up with all of these practitioners and follow up. So that's how we've handled that, and it's worked pretty well for us, I guess.
Yeah, I love that, Dr. Fetchy. Thank you so much for weighing in. Having had a hand in creating MCW's program, we did a similar task in moving our patients to more of a virtual discussion. I think we all recognize there's absolute heterogeneity with regard to how these patients present, right? You've got patients that are coming in, walking in the clinic completely asymptomatic, to those that are in status epilepticus and intubated in the ICU. Huge heterogeneity of how these patients present. So what we did actually was create a homegrown mobile application actually that we've utilized in order to align all of the disciplines kind of with an on-call structure where we at least have one doc from each discipline that's taking call by the week. And that way, regardless of how these patients present, we can at least triage them to get them to the appropriate disciplines, whether they're inpatient or outpatient. So just another tool that's being used in order to solve that same problem. I'm curious how you guys manage things here at UW in a similar way.
Yeah, I think that one of the main focal points that we have that works well is a multidisciplinary brain met or radiosurgery tumor board. And that's where I think a lot of multidisciplinary care and decision making is done here, and that works very well. That's been something that has been developed in recent years and has been really appreciated and effective. I think we don't, with some exceptions though, we don't have kind of a multidisciplinary clinic, especially dedicated to brain mets. Within our radiation oncology group, folks see kind of still based by disease rather than a brain met specific person. We have a CNS provider, but primarily they do primary CNS disease. whereas I myself do melanoma and I do the radiosurgeries for the melanoma patients and integrate with that group. And we have a lung provider who does the radiosurgeries for those patients. And so that's kind of how we've been operating. It's really interesting to hear the various alternative approaches. I think we don't have as many providers as Dr. Lee's group, obviously, so that we wouldn't be able to do kind of a full team of brain met focused people.
Right, I think we're like limited by definitely like even like in all of this like number of providers. And since I started, I kind of started organizing this, and the COVID came in. So a lot of things we still do virtual.
Yeah.
And we're building this big like outpatient hospital. So the plan would be to like materialize it more in person when we move to the outpatient facility, and at least have these providers physically in the same location.
One challenge I'll just add to the mix that we've had too is, neurosurgery, rad onc, palliative care. We all see patients in kind of a histology agnostic fashion, but that's not been true, obviously, for medical oncology, of course, because you have your melanoma specialist and your lung specialist and so forth and so on. And so medical oncology engagement into the program has been a little bit trickier. But what we've done is essentially identify typically a younger champion in each of those arenas who has an interest in brain medicine and niching themselves and developing a practice, and identified essentially a champion for each subspecialty within, like lung, melanoma, breast, et cetera. And then that person is kind of our go-to person for a lot of the either out or inpatient consults, for instance. And they're the people that are essentially staffing the inpatient consults as well. So.
Yeah, we took the same approach. We have a champion in each discipline, and sometimes that will take a little bit negotiation with their chair because, like what I mentioned earlier. We also, another thing you mentioned about a virtual visit. We were going back and forth on that, actually, especially during COVID. So right now we went back to the all in-person consult. The reason is mainly just to make sure that we have a good assessment of patients' KBS, neurological status. However, our medical oncologist oftentimes will see patients virtually, so they can be sitting in a different building, running their own clinic. And at the same time, especially if the recommendation is radiation or surgery, which is most of the case, and then they can just see patient briefly, virtually. But it is something that we're going back and forth.
Yeah, I guess one thing I should be careful about is I think I misspoke when I used the word virtual. I just meant from a center perspective. It's not a one clinic where everybody comes into the clinic. Is it's people are seeing all the different subspecialties under one roof, but we're not together in a clinic. So they go downstairs to see the rad onc, they come up to see me, so forth. And so it's a virtual center in the sense of it's not really just a single clinic. Sorry, so I misspoke there. I should have clarified. I apologize.
That's great. Thanks for clarifying, Dr. Fecci. We're at time for our break, so we're gonna pause.
One question.
Sure. Yeah, go ahead, Madhua. Go ahead.
Sorry, going back to lit. Have you done lit for like multifocal GBM? Like, would you do more than one lesion in the same person?
Yeah, I've certainly done two different trajectories. In other words, like two different incisions, and I don't think I've done as many as three. There is a time limit or not limit, but or factor, I should say, in kind of, adding trajectories. And also eventually these things all cause some swelling. So probably the most I've done is two separate lesions in a single sitting, which in a way kind of mirrors how you think about resection too, right? We don't go in and typically take out 4 lesions. And so from a metastatic arena, I've treated 2 lesions in one sitting. And in the same time, I've also resected 2 lesions in the same sitting. For a GBM, you could do something like a multifocal GBM, it provided that they're, both safe and amenable. Some people have tried doing things like butterfly gliomas or things like that. I think at the end of the day, if you wouldn't do it in an open surgery, you probably shouldn't really do it with the lit surgery either. And that's kind of a general rule.
Dr.
So
Fetchy, do you continue immunotherapy around lit, or do you require them to pause or anything?
Yeah, great question. So the short answer is I don't know the right answer here. And there's certainly good data that lit opens up the blood-brain barrier, and I didn't really talk about that today, of course. And there are a number of clinical trials in both the metastatic and the primary brain tumor arena out there looking at the combination of lit with immunotherapy for two reasons. One, the opening of the blood-brain barrier, and two, because hyperthermia and immune responses should synergize. And we have published preclinical papers showing that. We typically will hold most chemotherapeutics, immunotherapeutics for about a week on either side. I can't prove to you that that's the right answer. It's just a gestalt. And I think there are people who potentially don't hold it, and there are probably those that hold it longer. So I think the jury's still out. I think it's a very, very, very reasonable clinical question to ask and attempt to address. Because if there really is a synergy, clearly having those things reasonably proximal to each other in time would be a good idea.
may I ask one question?
Please.
Yeah, Dr. Fetchy. So how many of your neurosurgeons do lit at Duke?
Yeah, so I do it on the tumor side pretty exclusively, just because it's practice that I built and people just kind of send it to me rather than learn it on their own, I guess. We also have epilepsy surgeons and who both do it for mesial temporal lobe sclerosis, and then there's a pediatric neurosurgeon who also uses lit mostly for things like tubers or epilepsy as well. And actually, it works great for things like hypothalamic hamartomas are a great use. I've done that in a kid, kind of in a multi-D fashion, because that's a terrible spot to have to get to surgically. And we've had kids coming in, having many seizures a day, like gelastic seizures, and you put the laser in the hypothalamus, get the lesion, and they're seizure free in 3 days, and it's fantastic. But short answer is that was very long-winded of saying I'm the only person that does it for tumors here. Sorry.
Okay, thank you.
When you do it for radiant necrosis, where you have confirmation or biopsy that makes you think it's not recurrent disease, is your mindset to the approach similar to what it would be for a tumor, or are you kind of just debulking and knowing that you're leaving some necrosis because it's sort of just volume reduction? What is your thought process?
Yeah, I think there's a couple of schools of thought here. There is a school of thought there that there's two lines that you can see while you're heating. One's a yellow line and one's a blue line. The blue line is the thermal equivalent of 43 degrees Celsius for 10 minutes and is believed to represent cell death. So anything in the blue line is dead. And then the yellow line is the thermal equivalent to 43 C for 2 minutes. And it tends to be a larger area. So the difference between the yellow line and the blue line is thought of to be kind of an area of reversible heat damage, if you will, essentially like a penumbra. Some people will say that, for radiation necrosis, you really just need to yellow line it. The way I think about things is, even in biopsies, there's sampling errors, et cetera. So if I'm concerned about an area of eloquence immediately adjacent to the lesion, I may say, okay, I'm just going to bring the yellow line out there, and I'm not going to worry about blue lining it. But in general, my philosophy is if it's safe to blue line the lesion, I don't care what it is, I'm going to blue line it, because there may be 4 cells out there that we didn't catch in a biopsy, and might as well kill it. So that's been my philosophy. I know other people share that philosophy. So I think it's not, for me, it's not guided by diagnosis so much as it's guided by how safe is it for me to push the heat out in that direction.
Thanks.
All right, that's great. To our morning panelists, thank you again very much for sharing your expertise and the advances of treatment for brain metastases and central nervous system disease, including spine tumors. We'll take a little break. We will reconvene at 10:30. We have an equally impressive second half of our morning to come. So for those of you who are online, please stay logged in, and we'll look forward to seeing you back in about 5 to 10 minutes.
Thanks, everyone.
Thank you.
Thank you.
Thanks all.
All right. I hope everyone got a short break. Refilled your coffee. Welcome back for the next half of this symposium. And it's my pleasure to introduce our next speaker, Dr. Michael Veronese. Dr. Veronese recently joined us at UW-Madison from Indiana University as an associate professor of radiology. His clinical and research interest focuses on helping to translate innovative diagnostic or theranostic techniques to the clinic for patients with brain and spine tumors with special interest in PET and MR imaging. And today he'll be discussing the role of PET imaging in brain metastases. So, welcome, Dr. Veronese. Is he?
Thank you, Dr. Day. I appreciate that.
There.
I'm not sure my screen. Can you see that okay?
Yes, we can.
Great. So thanks again for the chance to give this talk today. I'm going to go over PET imaging specifically with brain metastases. I do have some examples from the glioma literature, but it's going to be pretty translatable to brain mets. I also want to mention that these tracers are either in clinical care or being translated into clinical care. So these are not as much on the investigational side, at least for the things that I'm going to show it for. My disclosures are that I have research funding from Blue Earth Diagnostics on flucyclovine, and I have various roles with Telix as they work to take the FET to FDA approval. By way of outline, I thought I would show the three radio tracers that I'm going to talk about, so the terminology is clear. The first one is 18F-fluoroethyltyrosine. So this is a tyrosine analog. It's an amino acid analog. And so you'll hear me say FET-PET for the most part, or FET-PET when I talk about this agent. The next one in the talk will be 18F-flucyclovine. And this is another analog amino acid that was originally approved in prostate cancer, but has also been shown to be very good in uptake in brain metastases, with also with a very low background brain uptake. And then the third one is gallium fibroblast activating factor inhibitor, or for short FAPI-PET. So I'll start with the FET-PET, and then I'd like to compare that to our more ubiquitously available oncological PET agent, which is FCG-PET. So we're pretty familiar with this for many brain metastases patients. This is an example of a patient with a glioblastoma, but the concept is very similar, where we have the issue of the fact that the brain loves glucose, and FDG is a glucose analog. So we're going to see very high brain uptake in a normal activity of the brain, which can present an issue with certain elements of characterization of tumors in the brain. So in this publication, this same patient underwent a FET-PET exam. And so I love to show this because it's just kind of an easy way to show the advantages. We get a significant reduction in the background brain activity because the normal brain is not looking routinely for amino acids, right? So that's not going to be upregulated in the brain. Whereas in the tumor, we're going to see that upregulation of the LAT1 receptor very nicely, because the tumor is really starving for amino acids for various cell machinery. So the mechanism basically is very simple too, is where we have these amino acid radio tracers that these two on the top here are fluorine 18 compounds, and the one on the bottom here is an 11C methionine compound. And so basically they're all going to be taken into the system L transporters, or the L type amino, large neutral amino acid transporters. And so then they're going to have various properties, but really they all act very similarly through almost the same mechanism, and then they'll have different properties. For instance, 11C met has only a 20-minute half-life. So This is something that you'd have to have a cyclotron on site for. So that's why the 18F compounds have been developed. In fact, 18F DOPA is FDA approved for use in Parkinson's disease and can be used off-label for brain tumor imaging. And it's actually really good. Some issues are that there is some nigrostriatal basal ganglia uptake, and so you have to kind of take that into account if you do utilize this imaging, but you can get access to it and you can image patients with it. And so various academic institutions do that. Probably worldwide and over the largest period of time, the greatest amount of information is known about FET because of some of its properties. It's very easy to produce relatively, and it's metabolically inert. So those are some things that you could do dynamic imaging with a lot better. But again, the take home point here is these are all very good. Again, that mechanism, and then the 3 examples I have for the L-amino type. This is a paper that was published showing nice LAT1 receptor immunohistochemistry expression in patients with various brain metastases who also then subsequently, or before that, had undergone F-DOPA imaging. And so this is kind of what this looks like. This is an example of small cell carcinoma brain metastasis to the brain from the lung. And then the one on the right here is somewhat more heterogeneous in its pattern. This is squamous cell metastasis to the brain from the lung. So we do get positivity, but we always have to take into account that there's also possibly some element of heterogeneity in the signal uptake. But if we compare those to the normal brain, obviously we've got very low LAT1 receptor expression. This is why this is not going to be very visible on PET when we image this receptor. I put this in here too because we always have the issue of treatment-related change. So there's going to be reactive astrocytosis that's going to have some LAT1 receptor expression. So we're going to need to come up with threshold cutoffs, for instance, for differentiating between progression versus treatment change for that reason. And then this is the example from that same paper showing high LAT1 receptor expression in a patient that had undergone an 18F DOPA, and this is very nice PET visibility of that metastasis. And then here's what it looks like on MRI. Zeroing in on FET-PET a little bit more, I mentioned some of its properties that are advantageous. So this is a synthetic analog, and actually we have data dating back 23 years now. So this was originated out of Europe, and it's been shown over and over again to be extremely effective in helping with brain tumor management. I'll show those international standards next. But basically, it's also more cost effective because there's less of complicated synthesis. In vivo stability is better than other agents because it's not degraded once it's internalized. And again, that element of doing other things beyond just static imaging is of much interest. So here are those international recommendations. This is the response assessment in neuro-oncology in the European Association of Neuro-Oncology back in 2016. And then again in 2019, they produced several standards recommendations for when do we want to perform amino acid PET, with FET being a very nice example of that within the context of clinical care. So the assessment period is basically, these are the potential periods you could image, and the recommendations are all of those periods. So from initial diagnosis all the way through routine follow-up towards the end. And then this gets broken down even further into more specific regions. For instance, this is shown to be superior for tumor delineation for resection planning. It is very accurate for hotspot localization for biopsy planning. Very nice for radiation planning, and all the way down to treatment response assessment in a stable patient down the road. So what does that look like? We put this into clinical practice. As I mentioned, I'm relatively new here at Wisconsin. I spent several years at Indiana University where we had expanded access IND use of FET. So we put that right in the context of clinical care, given all the data that was in existence worldwide. So because this is in clinical care, there was no limit to the number of patients we could enroll, as long as we felt that they could benefit. And we also included both high-grade glioma and brain metastases cases. So that's this is sort of a requirement that we had. We didn't really do low-grade glioma or other brain tumors besides this. And so we basically got approval to do any of those phases of the renal recommendations that I talked about earlier. Other things that I look for are, I prefer the lesion to be at least 1 centimeter in size. We can do smaller lesions, and if they're positive, then it's probably progressive. But if it's negative, then this could be a false positive. So that's something that we sort of scrutinize. And then the patient, especially with MRI, we try to reduce excessive motion. If you know, we'd have to do a shorter scan time or do PET CT instead as other options instead of PET-MR. So this is kind of what that looks like. This is a fusion PET-MR. We did other advanced imaging, including DSC perfusion and DCE perfusion. So you'll see examples of that, but so we collected that in everybody that we scanned from a clinical basis. So we did clinical follow-up. So this is, you know, when they go to surgery, that's the tissue diagnosis that we'll use to confirm whether the PET is correct or not. But I mean, far and above, we had 0 side effects, 0 complications from the use of this PET agent, got it covered through insurance, the vast majority, actually all of the times that we did the imaging. And so far, we're up to over 315 times that we've done this imaging. So we're quite experienced at this by now over the last 3 years. Areas that we're moving into really are this: how can we make our workflows better? How can we get better specificity out of the tissue? And so we're also working in these spaces with AI and radiomics. Dr. Pahlavi is going to give a talk on some of this in the next talk, which will be really exciting. So just to give you some cases, this from our sample set, and you know, perfusion is very good. For the most part, it works. And then there are times though when it fails. And so having that multimodality approach, the dual modality component really saves us here. So this is an example of where that happened. This is a patient with known lung metastasis. It had increasing mass-like enhancement in the right occipital lobe after having been given radiation therapy. So that's it right there. And the DSC RCBV, we get wipeout of that signal because of all of the internal hemorrhage that this tumor had undergone. So we weren't able to use the DSC perfusion for this. At IU, we did do DCEK trans, so we got areas that were very elevated and suspicious for tumor, so that was nice. And then we also did the hybrid FET PET with that, and so this is what that looks like. And this was very elevated in terms of signals, so this was very strongly considered to be progressive disease. So this patient went for resection and was path proven to be a metastasis. The second case that I have within the context of clinical care, this was a previously treated metastasis with increasing enhancement shown here that had been increasing consistently over a couple of exams. So they went for a hybrid FET PET-MR, and the DSC and the DCE are shown here. This gave us some problems because this lesion is along the cortical margin, and we were often run into a lot of vasculature out there, can make interpretation difficult sometimes. There was this area that was more medial, it was a little bit lower signal, but based on that and the combination with the K-trans, this was felt to be, this was given an impression of concerning for progression. But the PET was really just ice cold. There was no activity there. This was then the PET impression was given no concern for malignant tissue. So this patient was followed, and for a year and over time with no intervention whatsoever, that enhancement rescinded significantly. So this was confirmed that the PET was correct on this one. This is a glioma case, but it's a really awesome case to just kind of highlight the usefulness of the PET imaging. This patient had gone for resection, and then there was this increasing enhancement that was occurring along the margins. And then, of course, the question of whether this was treatment-related change or progression after standard of care. So this patient went for a hybrid PET-MR, which is shown here. The lesion was getting bigger, but it was markedly elevated on FET PET with tumor to brain ratio over 4. So we very confidently called this progressive disease. There was some delay in getting the patient enrolled in the clinical trial. So they got another MRI a month later showing increase in size, and then they actually disappeared off the grid. And I thought maybe they had passed or went to hospice, and sometimes we don't get follow-up on what happens to them, but they showed back up in our system 10 months later, and somebody had done surgery or some intervention on this, and the tumor from an MRI standpoint looked really mostly gone with a little bit of enhancement that we favored to be post-surgical. So we had the patient tracked and we followed them, and they actually had gone up to Northwestern for sonocloud focused ultrasound procedure after resection. And so this actually was one of the patients that was published in Dr. Sonnabend and Dr. Stoops' very nice paper on this focused ultrasound. So they actually sent patients to us down at IU to get the FET-PET-MR imaging. And this was, I had the patient come back and get another FET-PET 18 months later just to make sure there was nothing there. It was cold as all. So that was a really great treatment response. And again, at 21 months, still no recurrence. So that was really amazing to see that. We went on to publish this work. We got full data on all imaging parameters on 80 patients. Roughly half of those were high-grade gliomas and half were brain mets. And these were brain mets of all types. And then the gliomas didn't specify between MGMT methylation or IDH mutation. It was really so we could get a broad range of patients come through and make sure that regardless of the patient, we were able to help that patient. So we showed really nicely with statistics that we demonstrated better accuracy of the FET-PET compared with MRI for delineating this important issue of progressive disease versus treatment-induced changes. So on the chart on the right here, basically the yellow, the purple are MR perfusion parameters that we had for our patient sample set, and the PET did better significantly relative to that from the statistics of that. But I think the point here is that really PET is not supposed to replace MR. It is really complementary. I can't emphasize enough how much the confidence was increased in the diagnosis when you had really good signal on both the MR and the PET. It was just something that our clinicians really responded to and really liked that when that was available for them. And then this was we looked at all these different metrics, and we looked at what was the most accurate versus the least accurate for brain mets in particular. So that was the sample size of 38 for that patient set. And the ones that we used clinically were the FET-PET tumor to brain ratio mean, tumor to brain ratio max, the K-trans on the DCE, the DSC RCBV, and then this is volumetric increases in contrast enhancement over time. So we showed very nicely again that the PET was really helpful in these circumstances, and then the least helpful was just conventional MRI. My hope is that radiomics is going to change that and help bring that up significantly, so we have all PET and MR parameters that really help us in our diagnosis. And so this is some example of that in the literature. This is from my friend Philip Lohmann and Norbert Galdix in Germany. These patients underwent FET-PET-MRs and had radiomics assessment in 52 patients. They basically tested for the first time, can we incorporate radiomics of PET into MRI, the FET-PET, in patients with brain metastases? So they did a radiomics analysis, and the conclusion was not really testing as much whether it was better than standard of care. It was really to do this assessment of, if we look at individual radiomics for FET-PET, we get this accuracy. If we look at MRI radiomics, we do pretty well. But it's when we combine both of them that there was better accuracy for the combination of that. So, and that was for the differentiation between radiation injury and brain metastasis recurrence. Similar work is being done by Philip's group on looking at, can we use radiomics with FET-PET-MRI to predict PD-1/L1 expression using the same sort of pattern of looking at the tissue with a textual analysis standpoint. And so their conclusion for the paper, which was really nicely done and very recently published, showed that they could predict whether there was L1 expression in non-small cell lung cancer brain metastases by using this combined PET-MR radiomics metrics. So that concludes the FET-PET information. I'm happy to talk with you about that. We're actually bringing that to University of Wisconsin. Should be here hopefully in the first quarter of 2024. We're doing some work with the company Telix, who's trying to bring that to FDA approval. So that's what we've been really steadily focused on. The second agent is 18F-flucyclovine. So this is an agent that Blue Earth Diagnostics has, and it also is approved for prostate cancer, but is not used as much in that space. But it was also found to be very useful in brain metastases. So this is an example of that from the literature. So I'll talk about that next. 18F-flucyclovine has a very similar mechanism to the LAT1 receptor. So this is what we talked about already with the FET-PET, the other amino acid tracers with the L-type amino acid channel. This is the ASCT2 receptor, which the way I think of it is it's a glutamine channel. So that's the predominant amino acid that's taken through there. There's a small amount of LAT1 involvement with flucyclovine, but I think the predominant is the ASCT2 receptor. And then there's also orphan drug approval for imaging and glioma. So what does that look like? Very excitingly, Blue Earth has a phase 3 clinical trial called the Revelate trial going on in 19 different academic institutions. They've actually finished recruiting. So we should get the data on how this looks in brain metastasis, specifically patients after radiation therapy. So I'll come back. I can come back and give you the update on this if you'd like once that's available. But that should possibly bring it to FDA approval. And this just to show you what this looks like. So these were a study that was done before this clinical trial and published. And the goal was to discriminate recurrence from radiation necrosis in a relatively small patient sample set. The point here is just to show you what that imaging looks like when they had been radiated and had subsequent increasing enhancement. So this is a patient on the top that had something in the medial cerebellum, showed up very nicely on flucyclovine PET. So this dual modality component was really helpful. Same thing on this larger lesion down here was also proven to be a recurrent brain metastasis. So that's what that imaging looks like. And again, note the reduced background signal in the brain for that. We have a clinical trial that actually should open up this month. We have full IRB approval with Blue Earth with 30 patients with brain metastases. We are specifically looking at the addition of immunotherapy now as the next phase, and what we're trying to understand whether flucyclovine is good for both radiation therapy and in the presence of immunotherapies. And then when we get this increasing enhancement with that same question, we'll do the 18-flucyclovine PET. I also have an MRSS component to this. This is chemical exchange saturation transfer, also looking at mobile phase protein, APT-CES. That's a part of this study. It's basically doing that dual biomarker concept. And then where possible, we're going to hopefully get some tissue for this, but if it's treatment changed, then we'll have to follow them clinically. And then the last agent that is really exciting, probably a little bit earlier in its development than the other two agents that I think are going to hit the FDA approval within the next year, is the FAPI-PET. So this is something that a lot of folks here at the University of Wisconsin are really looking at closely. So what does that look like? The mechanism for that is really these fibroblasts that are out in the stroma. They're called cancer-associated fibroblasts when they're in the presence of a tumor. They're normally involved in a lot of different cellular processes, but when you have a tumor, they really start to remodel the extracellular environment to help that tumor grow. So there's cell invasion that it helps with, metastasis. It helps induce angiogenesis. It's involved in immunosuppression. So this FAP compound or protein is really something that the FAPI targets. And it helps, it helps with this question of tumor progression and therapeutic response. So this is 28 patients in this publication where they did a real nice study looking across a broad spectrum of different cancers, very nicely characterizing them. They didn't do sensitivity specificity because of the sample size across so many different cancers, but you can see really nicely, this may start to remind you of FDG PET, but I think there's some really important distinctions here. One, you don't see a whole lot of uptake in the liver, right? You don't see a lot of uptake in the intestines that you'd normally get with FDG. And in the next image, I'll show you very nicely the difference in the brain uptake. This is normally taken into the kidneys and the bladder, so that's a normal signal. So that's kind of showing, this next paper is showing that comparison, these patients with different cancers and metastases were imaged with both 18F FDG PET as well as the gallium-68 FAPI PET. And I think right away it's pretty obvious that this is glucose uptake in the brain. So we're going to kind of just not really look at the brain too much with FDG a lot of times, but imagine the potential for doing a whole body PET CT or a whole body PET MR if we have FAPI PET to try to get some sense as whether we could have brain metastases. I think that's going to be a potential game changer there, especially if that brain metastasis we already know is going to be taken up by the FAPI. And then this is another example from the literature showing that FAPI uptake in a brain metastasis, so that you get real nice signal because you just don't have that background brain activity. So at University of Wisconsin, we actually also have a study going on with Dr. Bhatti and Dr. Proste as the PIs, looking at the FAPI PET-MR in patients with glioblastoma. So we'll be getting the tissue biopsied after imaging and then do the tissue assessment to see which types of glioma, glioblastoma this is going to be most useful for. And we're actually imaging our first patient today, so that's kind of exciting. The last slide I have is just to show that there's a lot more going on here at UW with a lot of different collaborators in a very heavily multidisciplinary fashion. On the left are a lot of our PET elements. So we also are actively utilizing dotatate PET as well for meningiomas. We're in the theranostics space, as Dr. Morris already mentioned earlier. We're helping facilitate all advanced imaging with a special focus on PET-MR. And then on the right side, I mentioned some of the MRI components. Dr. Pallavi is going to talk a lot about the radiomics, which will be a nice talk. And then we're providing support for the neurosurgical specialties on a lot of the CSD tracking using image guidance in the intraoperative realm. Since we can incorporate PET, we can incorporate other advanced modality beyond MRI. And then there's initial work going on in the focused ultrasound realm, which Dr. Day is going to be spearheading that. So that's going to be an exciting thing. So thank you very much, and I'll take questions.
That was just an amazing talk, Dr. Berenice. Thank you so much. We're about at time for your segment and want to make sure we keep the afternoon running. So if you are okay hanging on the call until the panel discussion to answer some of the questions that have come through, that would be great. I think as an excellent dovetail to your presentation, as you had mentioned, it's my pleasure to introduce next Dr. Pallavi Tiwari, who's an associate professor in the departments of radiology and biomedical engineering. I'm very excited about this talk, and like I said, I think it complements your talk just with the utilization of AI and using big data in imaging analysis for all central nervous system malignancies, but more specifically here for brain mets. She's going to be discussing the emerging topic of the use of artificial intelligence, or AI, in computational imaging in brain tumors. Dr. Tiwari, thank you so much for joining us. And I know you're virtual, even though you're from UW-Madison, but it's a pleasure to have you here today.
Thank you so much for that kind introduction and for the opportunity to present. Sorry that I couldn't be there in person, but very happy to share some of the work we've been doing here at UW, and before that at Case Western, where I was previously employed. And so, as was mentioned, I had this sort of somewhat of a boring title for this talk around AI in brain tumors, but then I went to ChatGPT and I wanted to sort of make it more exciting. So this is the exciting title that ChatGPT recommended. So I decided to go with it, and hopefully I can provide the bite-sized hope that it suggested that the talk should be focused on. So with that, I will get started. So, again, going back to ChatGPT and the sort of influx of the AI approaches that are becoming more prime time for all of us in sort of different facets of life. Similarly, AI has really become the next frontier in global healthcare as well. And so according to the New York Times the number one technology that's going to rock our world is going to be AI in healthcare. And the similar trends are reflected, if we go back last 10 years, in terms of the opportunities that AI offers in cancer research. And so, there have been more and more investments, not just within the US, but internationally as well, along these lines. And similar trends are shown in terms of the number of publications that have come out in this space. And here on the left is a plot of the papers just on AI in imaging alone. And you can see in the last two decades or so, the number has gone up exponentially because of the increase in availability of more advanced computational resources, but also the computational approaches and also the hardware becoming cheaper. And that's reflected also in terms of the AI approaches that are being used in clinical practice. So there are over 400 FDA approved tools and technologies surrounding AI and radiology. And some of them actually do a pretty good job of improving, treatment decisions for radiologists and clinicians. So what I'm going to talk about today is sort of different facets of AI that we've been looking at in my group. So, since we're talking about brain tumors, what I thought is, I'd sort of give you an example of, and this is probably redundant information here, but just for the sake of completion, I've sort of listed the different data sets that are available for us to do the analysis on. So starting all the way from radiology, and in our case, we primarily look at routinely acquired MRI scans like T1 pre, post, T2, and FLAIR, just because for us, a big objective with AI and machine learning approaches is to get as much data as we can. But then, if there is a biopsy or surgical resection done, there is also pathology available that we could digitize and then analyze. And I'll show you some examples of how we do that in the context of brain tumors. And then lastly, molecular data, again, in case of brain tumors, we'd look at IDH, MGMT, and some of the known molecular markers. So we can look at all of this information. But the big advantage that imaging offers is that it sort of allows us to look at the entire landscape of the tumor. So assuming AI can do magic as we anticipate, it should be able to tell you this map of tumor heterogeneity and sort of, what's happening on the MRI scale as compared to, let's say, you take biopsies, you take molecular, you get molecular information from two different locations. It could look very different. And ideally, your imaging features should be able to identify that these two spatial locations are indeed different from each other. And then if there is pathology available, one could look at associations across radiology and pathology, the field known as radiopathomics, and then similarly radiogenomics, where you do associations of these AI-driven features, also known as radiomic features, with genomic information. Ultimately, to help us understand, provide some more mechanistic understanding of these subvisual features that you get on imaging. So in my group, we look at all of these different pieces of information and then combine them or leverage them in a way that allows us to ask some challenging questions. And this involves both deep feature extraction approaches, which means that it's a data-driven approach. So let's say we have thousands and thousands of scans. Can the model learn by itself what the differences are? Let's say, and I'll use, just sort of a simplistic example of differentiating cats from dogs. So if you have millions of cat images and millions of dog images, the model will figure out that the fact that, the face structure is different, the whiskers are different specific characteristics of cats and dogs that make them cat and dog. And so if there's a new image, then the model will predict whether it's cat and dog. But the challenge is that you do need tons of images for the model to be able to learn those intrinsic differences between those two classes. And then the second aspect of this is what's known as radiomic features or handcrafted features, wherein you start with some hypothesis. So there is, let's say in case of cancer, something about that specific cancer, and then you fit that hypothesis into the model, and then use the hypothesis to drive what the model is learning, right? And I'll show you some examples of that as well. And then we apply that for different clinical applications, and I won't have time to talk about some of them, but for today's talk, I'm going to focus primarily on developing computer-aided decision tools and also in the context of prognosis and prediction. So for today's talk, what I thought I'd do is, we've been hearing about AI and machine learning and what it can do, but really what we need to think about is, are these approaches intelligent enough to do what it claims it can do? And the way I sort of think about making them intelligent is really breaking them down into these three specific aspects that we need to carefully look at. Starting from interpretability, these features that we're developing that drive the models, can we understand what's happening under the hood? What, are these features giving us some information about the pathophysiology of the tumor that is relevant? The second aspect is generalizability, and this is a hard one because there's a lot of challenges with training machine learning models, and you see that in ChatGPT as well, right? There's hallucinations. It sort of randomly identifies information and plugs that in. So what we need to develop, especially in healthcare, is models that are generalizable. So if it works at UW-Madison, and it works, where I used to previously work at Cleveland Clinic, it also should work in India, and it should work in developing countries where we may not have access to the best scanners, but the model should still be generalizable. And then lastly is translation. And this is also a big one. As we are sort of building these approaches, we need to really start thinking about what the translational implications of these approaches look like. So with that, let me sort of jump into the first one, interpretability. And as I was saying, deep learning has a lot of potential. It can do amazing things. It can do magic. But really, the big caveat with deep learning approaches is that you need a ton of data. So the way we've been using deep learning is primarily been, let's say, in the context of brain tumor segmentation, because there we have, with the availability of, publicly available data sets like Brad's challenge and a bunch of others, and, work that we've done in-house as well with our amazing collaborators like Michael, who presented right before me, who've been helping us sort of looking at these scans and segmenting. So we now have a large cohort of studies that are well segmented, expert annotated, that we can then use to now build automated approaches to segment the tumors. And then similarly, in the context of digital pathology, we've been looking at using these deep learning approaches to identify some very fine detailed pathological attributes like hyperplastic blood vessels, pseudopalisading cells, and so on. And you can see that the deep learning models do a fairly decent job. And so what you're looking at here, the second column is the ground truth. The last column are the results from our machine learning models, deep learning models, and you can see that it does a fairly reasonable job of localizing some very difficult pathologies. But the challenge with deep learning is, as I said, we need tons of data, and in oncology, especially in brain tumors, we don't have the luxury of a ton of data because it's still a rare disease, and so we have sparse labels, sparse data sets, and then also the challenge with MRI scans is significant variations that are introduced from scanners inside. So it becomes all the more important to have data coming from different sites and really models that are robust, which is something that deep learning, is not necessarily great at. And then there is also this aspect of sort of the black box where, some of these deep learning models tend to be black boxes. And so the model question is, if you have a machine that has 90% cure rate as compared to a human surgeon with 80% cure rate, what would you do? And that's really a question that is evolving, and, people are sort of grappling with it and trying to answer. But one thing that has been clear to us is, as we work very closely with our clinical collaborators, and it's been clear ever since, I've been doing this for 20 years, it's clear that they want to know what's happening, right? They want to understand what's happening under the hood. Is it interpretable? Can I look at an image and make sense of what the model is doing? And that's what we've been trying to do with some of the approaches that we've been building in-house. And so in the context of brain tumors and in general with tumors, a big aspect is understanding intratumoral heterogeneity, because if we understand intratumoral heterogeneity, we understand tumor behavior and how a patient is going to respond to treatment, and start to ask some of the more difficult questions. And I'll skip this slide because all of you here know of brain tumors and how important it is to look at some of these concepts in brain tumors. But the first problem for me, I started working in brain tumors roughly 12 years ago when I was finishing up my PhD, and I started talking to a neurosurgeon who said, we really need your help. If these models can solve some of the challenges we face on a daily basis, that could be, that would improve quality of life for our patients and would help with improving their prognosis. So the first question he posed to me is, this question that, Michael was talking about as well, and a big challenge in the field of distinguishing radiation effects from tumor recurrence. So here I'm showing you 4 patients. 2 of them on the left are tumor recurrence, on the right are radiation effects, and you can see how similar they look. And I know Michael is on the call, but I was told that even for an expert, the accuracy is not great just because of how similar they look. So, when we started working on this, we said, worry not, we have the algorithm, so we can solve this. And then very soon we realized it's a challenging problem. There's a reason why, there's a struggle to be able to distinguish them just because of how similar they look morphologically on imaging. So what we did then was we came up with this feature called collage. And so the idea behind collage is really sort of going back to understanding the biology and trying to learn from the biology to be able to capture these differences. So this was the work that was inspired by a work that was done by my colleague, where they were looking at pathology slides, and ultimately what they were trying to do was to characterize the chaos in the tumor microenvironment. So, for example, we know cancer fundamentally is a very chaotic disease, grows in all sorts of different directions, and as compared to benign condition, which ultimately, you can, on pathology, you can see the differences between cancer and benign, and in this case, in distinguishing radiation effects and tumor recurrence. So we applied the same paradigm on imaging, especially on MRI scans. And so what we were doing here is looking at changes in gradient intensities. So we were doing it on a per voxel basis. I'm only showing you gradients for every 10 voxels just to improve the visualization here. But essentially capturing that idea of the underlying chaos. So what we did was, once we look at the changes in intensity shown as the gradients here, we then compute the entropy of those gradients, because we know from high school math, entropy is a measure of disorder. So if you look here where you have sort of these nicely organized gradients, you'll see that the entropies are much lower as compared to where you see more chaos in the image and the entropy values are higher. So then we applied this paradigm on distinguishing radiation effects and tumor recurrence. And we could see right off the bat, these are all patients that were predominantly radiation effects, predominantly tumor recurrence, confirmed on surgical resections. And we could see that the heat maps, the collage heat maps, were different, significantly different, with higher entropy values for tumor recurrence as compared to radiation effects. And so we took it a step further, after our initial analysis, where we said, okay, let's see if, we look at patients who have head and neck tumors that develop cerebral radiation necrosis. So that's the control on the left, as we call pure radiation necrosis, because we know that these patients did not have any tumor recurrence. And on the right was a treatment naive GBM. So we knew that, again, there is no radiation because this patient has not been radiated yet. So that was just to look at our controls and see how the entropy values look for those patients. And in between were patients that were surgically resected. So we knew that they had predominant radiation effects, more than 80%, and then more than 80% tumor. And you can see how there's sort of a nice gradient of changes in our collage values. So since then, we've, since a couple of years ago, and this is also actually an old slide, we're now collaborating with 10 different hospitals within the US and internationally as well. And we are continuing to collect these studies. And, one thing that we do take into account is histological confirmation. So all the patients are histologically confirmed either through multiple biopsies or surgical resections of whether they have radiation effects and tumor recurrence. And currently where we are is 89% accuracy of distinguishing these two conditions, which is quite promising. So, excuse me. I'll also briefly touch on some of the other features we've been looking at, just beyond looking at, features from the enhancing region. Also sort of looking at brain tumors as a systemic disease, because we know that it has an impact on the rest of the brain as well. So what we do is we sort of break it down as intratumoral, which is the enhancing lesion, which a surgeon would go in and scoop out. but the peritumoral region, which is the surrounding periphery of the tumor, and the extratumoral region, which is the rest of the brain, seemingly normal brain, but it's not normal because there's a tumor living in this brain. So that's we try to extract information from all of these different aspects and then combine them to build prognostic models. So this is an example of a work that we published a couple of years ago, where we were looking at these radiomic features, not just from the enhancing tumor, but from the tumor periphery as well. And then we demonstrated that inclusion of information from the tumor periphery improves our survival models. And then to further confirm, we wanted to see, okay, what happens when we have surgically resected tumors. So this was done on a very small study, because, it's challenging data to collect, but these for some patients, this is for using IV gaps data set, which is publicly available. So on some patients, they had done surgical resections, and they sectioned the tumor into multiple subsections, where every subsection was then quantified based on specific pathological attributes like cellular tumors, pseudopalisading cells, microvascular proliferation, and so on. So what we did then was we said, let's do a correlative study of our radiomic features and how they correspond to the underlying pathological attributes. And so what was most interesting, that the thing that came out of this study was that features that were coming from the tumor periphery were mostly associated with pathological attributes coming from leading edge, which again is a correlative study, but just to sort of give us some confidence that these features could perhaps be capturing something that could be fundamentally interesting from both the biology but also the machine learning perspective. And then another feature is sort of, looking at information beyond the lesion and its surroundings, trying to capture mass effect, which is displacement of the surrounding tissue due to peritumoral edema. So here what we did was this, rather simplistic approach, where we look at a normal brain, right? Normal atlas, MNI atlas, a well-established normal definition of a normal brain. And then we take a diseased brain MRI and then register that on top of the normal atlas to quantify the tissue deformations on a per patient basis. So what you're looking at is sort of just the changes in tissue deformations with respect to that normal template. And then what we showed was that these tissue deformations were a lot more prominent for patients that had poor survival compared to patients that have improved survival. And this is just another representation of that. And so you can see how the deformations are a lot more enhanced closer to the tumor's the surface of the tumor, which makes sense, where you would expect the brain to deform more. But we also found differences between statistically significant differences between short-term and long-term survivors. Some of these features that I presented, that I just shared, are publicly available, funded through an NIH grant, where you can go and play with them, plug in an MRI scan, it'll give you a collage map. In the end, I'm just going to skip this in the interest of time. And another thing that I didn't get a chance to talk about is also another feature that we've been looking at that sort of quantifies the 3D morphology of the lesion, and then you could go in and sort of create a 3D morphological template of the tumor that you could start to look at, and how the surface changes between different kinds of malignant tumors. Now I'm going to segue into looking at data, associations across different length scales and how that can improve our understanding of the disease. So in the context of this work, we were looking at tumor hypoxia, which, as we all know, is a major contributor of tumor heterogeneity, and is also associated with figuring out patients who are going to be resistant to radiotherapy, and ultimately, associations with poor response. So here, what we were doing was we looked at patients that had their genomic signature available. So we created a 21 gene hypoxia signature, and so we did unsupervised clustering to segregate these patients as having low hypoxia, medium hypoxia, and high hypoxia, using hypoxia index, which is a summation of all the different gene signatures, the 21 gene signatures. And then we correlated this hypoxia index with the radiomic features. And so what we were able to show in this work is that patients who tended to have high hypoxia had a very different radiomic signature compared to patients who had medium hypoxia and low hypoxia. And then when we feed these MRI signatures for survival analysis, we could see that there were differences in short-term and long-term survivals for glioblastoma. And ultimately, where we think this could have an impact, and this is something that I've just started to work on, is see how these hypoxia correlated imaging signatures, if they can also help us predict response to chemoradiation for these patients. This is some of our most recent work where we've been looking at sex differences in our machine learning models. And we know in glioblastoma that's relevant because patients tend to have men tend to have worse outcomes to glioblastoma as compared to women, but this has been shown for other cancers as well, where there is sexual dimorphism in response and prevalence of cancer. So we wanted to create, extend our radiogenomic models to build them in a sex specific manner. And so this is sort of our pipeline for doing radiomic analysis. But interestingly, when we break down the pipeline where we train the models specifically on men and specifically on females, we see that the survival models tend to be a lot more significant and improved in distinguishing improved and poor survivors in brain tumors. And similarly, if we extend that to radiogenomic analysis, what we were finding was that women that tend to have improved outcomes, their signatures, their imaging signatures were mostly correlated with immune response, pathways associated with immune response, which again intuitively makes sense. These patients tend to have an elevated immune response, they tend to have better responses to the treatment as compared to men, where men that tend to have worse outcomes, their signatures, MRI signatures, are mostly correlated with cell adhesion, angiogenesis, apoptosis, and cell migration. Again, all hallmarks of a glioblastoma. Since then this is some of our most recent work where we've extended our discovery of signatures across men and women. So we did this analysis on digitized whole slide images, H&E slides, where we were able to show that there are differences. Of course, the pathological signatures are different between men and women, between high risk and low risk patients. So there is some commonality in that microvascular proliferation was one pathological aspect that emerged both in men and women as correlated with high risk. Excuse me. But there were also some differences, like pseudopalisading cells were specific to men, while infiltrating tumor was more prevalent in women, correlated with high risk of poor survival. We've also been looking at, in the context of digital pathology, I'm just sort of showing some examples here, but feel free to reach out if there are questions. I know I'm going through some of these concepts rather quickly, but just wanted to give you some examples of the different types of works that are happening. So feel free to reach out to me if there's interest in any of them. But this is, again, some of our recent work where we've been looking at pathology slides and quantifying tumor infiltrating lymphocytes and correlating them with response. And so again, in a sex specific manner, we were able to identify that the signatures of tails compared to non-tails in pathology were different across men and women as it correlates with their survival. So what does this mean? How does this sort of come together? Because I've shown you a couple of examples of looking at imaging signatures, some examples of correlations with gene expression data and pathology slides. And so the way I envision this, which is a little bit futuristic at this point, just because of the challenges with brain tumors and how limited we are in terms of drugs and treatments that are available. But in an ideal world, once we get to that point, what I envision, this would look like is let's say, we have a female with a brain tumor. We'd get their imaging signature, and how it correlates with gene expression data, and we would have their pathology slides that we could analyze. So either an integrated biomarker or perhaps correlations across these lens scales that we could look at in a tumor board setting. But ultimately, to be able to identify that this patient is perhaps not a candidate for the traditional chemoradiation treatment, but perhaps would be more suited for targeted therapy options, depending on how their biomarkers look like. So that's where I think the field is headed. And then briefly, I wanted to show you some aspects of generalizability and how we've been looking at generalizability. And this is important for machine learning because we know garbage in, garbage out. If you train the models with sort of garbage information, you're not going to get meaningful results in the end. So what we've been very careful with is sort of making sure, since we work with a lot of retrospective data coming from multiple different sites, we have to be careful about the artifacts when we train these models. And so we've developed this graphical user interface called Marquee, and it's an easy to use web interface where you could just Google Marquee and it opens up a web interface. So the way it works is, and I might have a video here to quickly show you how it works. So you would sort of point to all the large cohorts of data that you have, and then it sort of computes their quality measures like SNR and a bunch of other image measures, and then it does these visual analyses to tell you what the differences are in your imaging scans. And then it creates these 3D plots, the TSNE plots, and it tells you if there are specific clusters of outliers. So let's say data coming from one site is just so different from the rest of the data sets that you got to figure out a way to homogenize your studies before you train the machine learning models. And that's something that you could do using that tool that we've built, and we use that for all of our analysis before we get to the machine learning part. And lastly, in the last 5 minutes that I have, I want to show you some examples of translation and how we've been using these approaches, or we're thinking about using these approaches in clinical practice. So I'll go back to this question of distinguishing radiation effects and tumor recurrence. So one thing that we wanted to do is to see how well these models do, how well the classifiers do if we compare them with two neuroradiologists. So we did this study again a couple of years ago where we had our radiomic models, and ultimately we'd get a probability from our classifiers, zero being zero being radiation effects, 1 being tumor recurrence. And then we set up a similar parallel study for our two neuroradiologists. So this is all retrospective data where we had the path reports, but the radiologists were blinded to the path reports. And so they were given access to the same multiparametric MRI that the machine learning model had access to, which is gadolinium pre, post, T1 and T2 and flare. And then we asked them to make a decision, even if they're not confident, make a decision of whether it's radiation effects, tumor recurrence, and then give us a confidence score, 0.5 being coin toss. They had no idea. They just called one over the other, and one being 100% confident of the decision that they were making. And these were our results. And I know that there might be some radiologists on the call here, but that's what the data showed. Accuracies of 42% and 50% by the two expert readers. And our machine learning model was not great, but it's still 75% and statistically significantly better than the two experts. And we saw that the inter-reader agreement only existed in 30% of the cases. I will mention, though, that the big caveat with this study was that we did not give the readers access to any other information than just that one static time point with T1 pre, post, T2 and flare, which is what the model had access to. So they did not have access to PET or to perfusion or any other advanced imaging, just routine MRI scans. And that's probably is what's reflected in the lower accuracy values here for the two readers, just because we really limited them to very specific kind of data. And then this was one of the first studies to show results like that. And so it made to this sort of, sensational title, Computer Better Than Doctors at Diagnosing Brain Cancers. And clearly there was sort of some backlash from the community. So this is an editorial that came out after this work titled, Am I About to Lose My Job?, written by a neuroradiologist. And that's when it occurred to us that perhaps the message that we wanted to convey was not to, which has always been the intent, but perhaps was not reflected in the way we did the analysis, wherein we did a comparison. But what we should have really done is working with the clinician, working with the radiologist and seeing what the improvements would look like. So we did a follow-on study where we had the two readers sit together and then make a decision. So accuracy goes up to 67%, much like what you would see in a tumor board setting. And then we had the readers look at the output from the machine learning model and include that into their decision making. And that's where the accuracy goes up to 92%, which is again very encouraging for us, because even with stereotactic biopsies, the accuracies are between, close to 90%. So, with the non-invasive approach, with incorporating expert knowledge into our models, we could get accuracies in the range of 90%. And we did miss one case, which was misdiagnosed by both the experts and the classifier, and we still don't know why that happened. So that's something that we are looking at. So where we are is we are collaborating with GE Healthcare in sort of incorporating some of these models into their GE Health Cloud. And the plan is to do it in a prospective setting where we would have our radiologists read the scans like they would in without the help of a machine learning model for the clinical use, and then we would have them look at the same scans in conjunction with the AI to hopefully demonstrate that there is value in looking at these AI approaches. And lastly, very quickly, I wanted to show you another use case of where this AI could have impact in clinical care, is to sort of assist neurosurgeons in doing biopsies. We all know that it's challenging, it's not perfect, there's morbidity and mortality associated with doing these biopsies. And so we have a collaboration with BrainLab where what we're trying to do is to read these heterogeneity maps in a DICOM format that we could then map onto a preoperative MRI and hopefully in an intraoperative setting to do clinical trials, much like what Michael showed towards the end of his slides. And then we're hoping to be able to do this here at UW. So with that, I'd like to conclude. And I know I showed multiple different examples, but hopefully I was able to convey that computational imaging and AI have the potential to complement personalized prognosis and treatment response to address questions such as who to treat, how to treat, did the treatment work. Also showed you some examples of radiogenomics and radiopathomic studies to look at interactions across different length scales to ultimately get to a point where we can have some biomarkers for prognosis and treatment response, and certainly very important for brain tumors and the kind of challenges that we all look at. And lastly, the exciting opportunities that these approaches offer in radiology, radiation oncology, and surgery, where, in conditions like brain tumors where treatment options are limited. So with that, I'd like to thank the funding agencies that have made all of this work possible, but a big shout out to the team behind all the work that I get to present. The students, postdocs, research scientists, we all work very closely together, and our clinical collaborators who provide the data and help us understand the clinical questions and work with us to be able to answer them. And thank you all for your attention.
Thank you so much. That was a great talk, and we'll save all the questions towards the end. All right, we'll keep moving and we'll hold off all the questions for Dr. Tiwari till the end during panel discussion. Next, we're going to switch our gears a little bit, and we're going to discuss about medical therapies for brain metastases. So with that, I'm excited to present our next speaker, Dr. Jonathan Thompson. Dr. Thompson is an assistant professor of medical oncology at MCW. His clinical interest focuses on management of brain cancer with special emphasis on novel clinical trials. And today he'll be discussing the impact of systemic therapy on brain metastases.
Okay, well, thank you for giving me the opportunity to talk with you all today and letting a medical oncologist crash your party. Are you able to see my slides okay?
We can, John. Thank you.
Okay, great. All right, well, so really today wanted to just kind of give a sense of how as medical oncologists we think about brain metastases and think about how our systemic therapies can potentially help treat them. All right, so here are my disclosures. So this is a massive topic, and in 30 minutes we won't be able to cover everything, but really just wanted to focus on a few kind of key points. One, just reviewing some of the principles of what we think of as a good systemic therapy for brain metastases. We'll use some case studies to show the capability of systemic therapy to manage brain mets. And then we'll talk about some of the challenges that we face and some of the future directions in medical oncology and treating brain mets. And so just to set a little background for what we'll talk about today, we'll focus predominantly on the three major cancer types that lead to brain metastases, with lung cancer being the most common, and then breast and melanoma. In interest of full disclosure, I'm a thoracic oncologist, so definitely more familiar with the data there, but I'll give it my best shot for breast and melanoma, and apologize if Dr. Shatambar is still on the line if I screw up anything with breast cancer. All right, so when we think about the best, what is the perfect therapy from a systemic therapy standpoint for brain metastases, so there's some pretty simple concepts we think of. So obviously, we need drugs that can penetrate into the CNS and overcome the blood-brain barrier. Once the drug is there, we need it to have great cancer cytotoxic effectiveness. And so if the drug gets to the brain well but doesn't kill cancer cells, it's relatively useless to us. And then we need safe drugs. So the concentrations needed to cause cancer killing effects in the brain need to be doses that are tolerable for the patient. So we need drugs with good therapeutic indices. So when we look back historically, 20, say, plus years ago, and we look across different cancer types, we were predominantly treating our metastatic patients with chemotherapy. And unfortunately, chemotherapy really doesn't check any of those boxes for an ideal systemic therapy for brain mets. When we look at specific disease types like non-small cell lung cancer, we see relatively low CNS response rates in the 30 to 40% range with short intracranial progression-free survival. Breast cancer, a fairly similar story. And when we look at even our most chemosensitive cancers like small cell lung cancer, we see higher response rates with multi-agent chemotherapy, but still affecting a relatively small survival benefit. So chemotherapy, serves as a backdrop of how, what we hope to improve upon in the future. And unfortunately, over the last 10 plus years, we've had significant advances in systemic therapy for most cancers, and these have impacted management of brain metastases. And so, one of the key things we think about in medical oncology, and really our multidisciplinary brain met approach, is what are the best ways to sequence our therapies? Where do we start with systemic therapy? Where do we start with radiation or surgery? And just so this isn't just me telling you what I think should be done, I'll use some guidelines as a backdrop. These are consensus guidelines from ASCO, SNO, and ASTRO, published a few years ago. There are other guidelines out there, but I think these mimic our practice at MCW fairly well. And so just a few kind of straightforward guidelines that kind of set the table for sequencing therapies. So patients with symptomatic brain metastases in general, with rare exceptions, we will approach those patients with local therapies like radiation or surgery first, and then sequence in our systemic therapies later. For patients with asymptomatic brain metastases, I think the jury's out a little bit more on this, but for patients who have compelling systemic therapies that have a high intracranial response and durable responses, we will commonly lead with those first, but those without great systemic therapy options that have lower rates of intracranial control will commonly lead with local therapies, and we'll kind of outline some of the different scenarios where we may use certain medications over radiation or surgery. And so the first kind of class of drugs we'll focus on are targeted therapies. And when I talk about targeted therapies, what I'm personally meaning is essentially medications that kill cancer cells by specifically targeting proteins that are either mutated or overexpressed in the cancer cell. And so for some examples, on the far left, we have EGFR, which in about 15% of lung adenocarcinomas is mutated, where the kinase domain, the intracellular kinase domain of the protein is mutated, causing constitutive signaling that causes cell growth and metastasis and invasion. In EGFR mutated lung cancers, we have tyrosine kinase inhibitors that inhibit the kinase domain and kill cancer cells. In the middle, we have our patients with melanoma, about 50% will have BRAF mutated melanoma. And here the RAF mutation leads to downstream signaling through MEK and ERK pathways. And we have effective therapies that block both RAF and MEK to cause disease response. And then finally, on the far right, we have our HER2 positive breast cancer patients, which account for about 20% of patients with breast cancer. Here we have numerous therapies that act in different ways, either binding to the extracellular domain of HER2, preventing HER2, HER3 dimerization, or inhibiting the kinase domain of HER2. And so when we focus first, starting with lung cancer, here we have probably the broadest array of different mutations that we have therapies for at this point. We have these things called driver mutations, which are basically single mutations that do exactly that, drive the growth of the cancer. And by inhibiting those mutations, we cause cell death. Here we have, in lung cancer now, we have 9 different driver mutations that have FDA-approved therapies. And when we look at patients with lung adenocarcinoma, about 40% of them will have some sort of driver mutation. So taking a patient from my clinic, this is a 65-year-old lady who had multiple lung masses and multiple small brain metastases that were asymptomatic at diagnosis. She was a non-smoker. She had a lung biopsy that showed lung adenocarcinoma, and genomic testing showed an EGFR mutation. And so this was back in August of 2019. She was started on our standard of care EGFR tyrosine kinase inhibitor called osimertinib. Within 3 months, all of her brain metastases resolved, and she remains on osimertinib to this date, 4+ years later, still with no evidence of disease in the brain, good control outside of the brain as well, and she's not had any local therapies to date. And so when we look at, kind of drill down into the evidence behind this, when we look at just osimertinib, our modern EGFR TKI, and how patients just do in general from an overall survival standpoint, we now see that osimertinib, is better than chemotherapy, better than our early generation EGFR TKIs in terms of overall survival. And we have now data showing that patients with metastatic EGFR mutated lung cancer are expected to live on average over 3 years with their disease. And so with patients living longer, we need drugs that have good brain control and prevent or treat active brain metastases as time goes on. And fortunately, osimertinib is able to do that. So if we look at the actual CNS data with osimertinib, we see intracranial response in about 66% of patients with osimertinib. And actually in this study, there was no patients with progressive disease on osimertinib after initial response. When we look at the durability of that response, we actually see, if we look at the cumulative incidence curves on the lower right-hand side, we see the solid blue line is CNS progression, and then the dotted blue line is non-CNS progression. So we actually see that patients more commonly will progress outside of the CNS before progressing in the CNS with this drug. And the additional benefits of osimertinib are that it inhibits the mutated EGFR protein better than wild type EGFR. So we see far lower side effects with this drug than our earlier generation EGFR therapies. So when we think about our kind of ideal systemic therapy, this is one that has high CNS activity as well as extra CNS activity and is very tolerable. So it kind of checks all of those boxes. So the good news with lung cancer is that a lot of our drug development for these driver mutations has been focused on not only designing drugs that are effectively inhibit the protein that's activated, but also drugs have been designed to better accumulate in the CNS. So most of our studies and our efforts nowadays keep that endpoint in mind, that CNS control is a huge part of the success of our therapies. And so when we look at some of the other kind of common driver mutations that we encounter, including ELK and ROS1, we see that the intracranial response rates are high with these drugs, many of them in the 70 to 80% range, and that many of these are actually very durable responses that we're seeing. Now, if we flip to breast cancer, so HER2 positive breast cancers tend to have somewhat higher rates of brain metastases. And here the data is a little bit more mixed, with some of the earlier HER2 therapies having somewhat lower response rates and progression-free survival in the brain. Although we do see some combinations having responses in the 40 to 60% range that can be somewhat durable. The new kid on the block in terms of HER2 positive lung cancer, or I'm sorry, breast cancer, is a drug called trastuzumab deruxtecan, which is an antibody drug conjugate that delivers chemotherapy directly into the HER2 positive breast cancer cells. This is our most kind of powerful HER2 antibody drug conjugate on the market right now. And at least in a couple of different small studies, we see encouraging response rates in the brain. So in one study, a 73% response rate, in another 58% in duration of response over a year in one study. And so this drug, you could see a scenario in the future where this gets more commonly sequenced in earlier, perhaps, allowing us to delay local therapies for asymptomatic brain metastases. When we look at other therapies for breast cancer, so our endocrine therapies have relatively limited data supporting their use as a primary agent to treat brain metastases. When we look at patients with hormone receptor positive breast cancer, many of them will receive CDK4/6 inhibitors, and there is some data for their CNS response, a phase 2 trial showing a drug called abemaciclib having pretty limited activity with a response rate of only 5% in the brain. Moving on to melanoma and brain metastases. So again, about 50% of patients with melanoma will have a BRAF mutation in their cancer. And this study looked at a combination of a BRAF inhibitor called dabrafenib in combination with a MEK inhibitor called trametinib. And there were multiple cohorts in the study. You can see on the left, some with asymptomatic untreated brain mets, some with asymptomatic previously treated brain mets, and then even a small cohort with symptomatic brain mets. And what we see across most of these cohorts is in response rates in the upper 50% range. In terms of the durability of that response, though, we're seeing lower durability than what we saw with some of the lung cancer targeted therapies. And so when we kind of come back to our guidelines then in terms of what people think is a reasonable strategy for sequencing in these targeted therapies, when we see our lung cancer targeted therapies like osimertinib for EGFR mutated lung cancer, or say our ALK mutated lung cancers using alectinib, brigatinib, et cetera, there the data is at least somewhat compelling to start with patients with asymptomatic brain metastases, reasonable to start with the targeted therapy first and to defer local therapy until evidence of intracranial progression. For the other mutations that I mentioned, again, at least at MCW, we will commonly, even though the data, again, is a little bit less mature in those places, if the agents have reasonable response rates and durability of control of brain mets, will potentially lead in with the targeted therapy still in those situations. For HER2 positive breast cancer, at least when these guidelines are published, the combination of tucatinib, trastuzumab, and capecitabine were thought to be a potentially reasonable starting point for asymptomatic brain mets before considering local therapies. One imagines that trastuzumab deruxtecan would potentially work its way into the next iteration of guidelines. All right, so moving on to our, I guess, newest, although maybe not so new anymore, generation of systemic therapies for cancers would be immunotherapy. And so immunotherapy here what we'll be focusing mainly on are two classes of drugs. First, on the far left is the CTLA-4 inhibitors like ipilimumab and tremelimumab. These drugs predominantly help with T cell priming, T cell activation at the level of the tumor draining lymph node. And then our other class of drugs called PD-1 or PD-L1 inhibitors with some of the FDA-approved drugs listed below. These drugs block PD-1, PD-L1 signaling, which keeps T cells active in the tumor immune microenvironment. And so why immunotherapy has been all over the presses and studies over the years is that we see just dramatic improvements in survival across the board for many cancers. And so when we look at lung cancer and we look at certain subgroups of lung cancer, those with the biomarker PD-L1, which in lung cancer selects for patients who are more likely to respond to immunotherapy, we see that for PD-L1 high lung cancers, non-small cell in particular, that we see now patients with 5-year survivals of 31% with PD-L1 high disease and receiving a PD-1 inhibitor called pembrolizumab. If we compare that to say, 20 years ago where we had just chemotherapy for metastatic non-small cell lung cancer, the 5-year overall survival there was less than 5%. So we've certainly dramatically improved our survival for these patients. Not to be outdone, in melanoma on the far right here, we have a trial looking at numerous combinations or single agent immunotherapies. And we see for a combination ipilimumab and nivolumab that the 5-year survival in melanoma is over 50%. And so again, these are patients who historically in the age before immunotherapy did poorly, and now we have these really dramatic benefits in survival seen with these drugs. And so again, just highlighting that these patients live longer nowadays. We need to keep surveillance on the brain as they live longer. And so here's an example on a patient of mine who had basically at diagnosis multiple lung lesions, had multiple small asymptomatic brain metastases. She had a biopsy showing poorly differentiated non-small cell lung cancer that was PD-L1 high with an expression of around 70%. She went on to receive the PD-1 inhibitor pembrolizumab, and within 3 months had a complete response in the brain. And then if we fast forward to her most recent scans, we're still seeing no evidence of disease in the brain. And she's getting alive and well 5+ years after starting her pembrolizumab. Now, when we actually look at the data for, what is the actual response and durability of these responses in the brain for a checkpoint inhibitor or for immunotherapies with lung cancer, there's actually very kind of shockingly little data in this space. So there was one small phase 2 trial looking at patients who with metastatic non-small cell lung cancer who have brain mets utilizing pembrolizumab. And what they saw was that in patients who had PD-L1 positive lung cancer, the response rates in the brain were about 30%, duration of response of about 5.7 months. And interestingly, only about 19% of patients had both an intracranial and extracranial response. So there was a discordance between responses in the brain and in the rest of the body. Importantly, PD-L1 negative patients had no response in the brain to pembrolizumab. And so at least in lung cancer, biomarkers are still very, very important. This study was done in quite a long time ago, designed quite a long time ago before we understood the full impact of PD-L1, and so these numbers don't necessarily reflect what we would expect, say, with PD-L1 very high patients, as there was a relatively small group of patients in this study. Interestingly, there's been multiple studies looking at concordance between PD-L1 expression in the brain and the lung primary. And in one meta-analysis, there was a discordance of about 20% between PD-L1 expression in the primary tumor, and the paired brain metastasis. And where we saw the most significant discordance was in PD-L1 kind of low patients, so PD-L1 of 1 to 50%, there was a little bit less frequent expression in the brain than in the primary tumor, whereas PD-L1 high patients, it was relatively similar. Relatively similar in PD-L1 high and PD-L1 negative patients. And so that, again, that just opens up the, our previous speakers were talking about using new imaging to try to assess PD-L1 expression in the brain, and that's certainly something that may be of clinical value, as again, we don't commonly get brain biopsies on all of our patients. In terms of other data for non-small cell lung cancer and using immunotherapy to treat brain metastases, we do have one phase 2 trial looking at chemo plus a PD-L1 inhibitor called atezolizumab for patients with asymptomatic brain metastases without prior local therapy. And here we saw response rates in the mid 40% range, duration of response in the 12 to 14 month range. And again, here there were 4 discordant responses. And so right now, at least the data behind using immunotherapy prior to or in lieu of local therapy is still relatively limited for non-small cell lung cancer. In melanoma, it's somewhat of a different story. We have a few different trials looking at utilizing immunotherapy for untreated brain metastases that are asymptomatic. Here we look at a combination of ipilimumab and nivolumab. We see intracranial response rates in the 53% range, which was actually higher than the extracranial response rate. And we see very durable benefit in the brain with Ipi and Nivo. When we look at another study that compared the combination of ipilimumab and nivolumab to just nivolumab, we see much higher response rates with the combination of Ipi-Nivo compared with just Nivo by itself. Again, the durability of that response better with the combination of Ipi-Nivo than with just Nivo by itself. And so when we look at what do our guidelines say about using immunotherapy for sequencing with local therapies for lung cancer, at least the only kind of indication that the guidelines recommended was to use chemo plus pembrolizumab for patients who have asymptomatic brain metastases, although the level of evidence is low. For patients with asymptomatic brain mets and melanoma, again, Ipi-Nivo or dabrafenib trametinib, again, being potentially offered to patients with asymptomatic brain mets. And so then moving on for the last few minutes in terms of some of the challenges that we face with systemic therapy and how to sequence it with local therapies. So as you might have kind of gathered from our guidelines that we just reviewed, the level of evidence about how to sequence systemic therapy with local therapies is very low level evidence, very little prospective and very little randomized evidence in that space. And so the algorithms that we talk about have not the highest level of confidence with those recommendations. And part of the reason that is that most clinical trials exclude patients with untreated brain metastases. So it's very common that they require some sort of local therapy and then stability of the brain metastases for a period of time before being able to enroll in a trial. And that the retrospective studies that we have then in lieu of the prospective studies, unfortunately carry just innumerable biases that really make it difficult to really use those as high level evidence to guide our treatments. And so clearly we need better trials, better trial designs to help us understand what is the best sequence of systemic therapy and local therapy, particularly for patients with asymptomatic brain metastases. And the kind of cold hard truth is that it's going to be nearly impossible to design a trial that fits every single one of our patient populations. Is it really possible to stratify patients on across different cancer types, different biomarker selected, extent of disease, symptomatology, is it really possible to design trials like that? It's likely not possible for every scenario, But what is possible is to, be advocates for our patients, allow, when we're meeting with pharma or designing trials ourselves, advocating for, more flexibility and inclusion criteria to potentially allow asymptomatic brain metastases patients on trial and have that flexibility to keep them on trial and to do local therapies if they do progress just in the brain on trial. And so just to summarize in the last minute here, we have made huge gains over the last few decades in terms of our systemic therapies. That chemotherapy, our treatment of the past has limited efficacy in the brain, but our modern targeted therapies and immunotherapies are showing more promise in inducing durable brain responses, obviously dependent on cancer types and tumor biomarkers. And that, again, we need better clinical trial design, better clinical trials to help us understand what the best sequence is, what the role for local therapy is in the age of modern effective systemic therapies. All right, so with that, I'd again like to thank everyone for listening to me today.
All right. Dr. Thompson, thank you so much. I get to call you John just because we worked together for so long. So, John, amazing talk in assimilating what is, an ever expanding field of targeted immunotherapies specific for the use of brain metastases. Thank you so much for consolidating that for us in a digestible way within 30 minutes. I appreciate you. We'll hold some questions until the end. Last but certainly not least, for our panelists for the second session is Dr. Milani, who's an assistant professor in the Department of Neurosurgery at the University of Utah and is also a clinical investigator at the Huntsman Cancer Institute there. She's a neuro-oncologist and treats patients with gliomas, primary CNS lymphomas, and obviously metastatic disease. She's going to talk to us about another very challenging conundrum with central nervous system metastases, which is leptomeningeal spread of disease. Dr. Milani, thank you so much for joining us from Utah. We appreciate you and look forward to your talk.
Thanks so much for having me. Hopefully you can see my slides. Yeah, thank you so much for this opportunity. I'm excited to talk to you a little bit about an introduction to CNS Mets with a focus on leptomeningeal metastasis. So I thought we could sort of talk a little bit about LMD, clinical presentations, how to work up and evaluate patients, and then just some of the treatment strategies as well. I wanted to open with this excerpt from an essay from the New York Times penned by Dr. Paul Kalanithi entitled, "How Long Have I Got Left?" He was a neurosurgeon at Stanford who was diagnosed with metastatic non-small cell lung cancer. And as he was diagnosed, he wrote this essay. So in it, he writes, "I began to realize that coming face to face with my own mortality, in a sense, had changed both nothing and everything. Before my cancer was diagnosed, I knew nothing. Before my cancer was diagnosed, I knew that someday I would die, but I didn't know when. After the diagnosis, I knew that someday I would die, but I didn't know when. But now I knew it acutely. The problem wasn't really a scientific one. The fact of death is unsettling, yet there is no other way to live." This has always stood out to me because it so beautifully encapsulates the existential crisis our patients face every day with this concept of time. Time to, how long will their therapy last? When will they have more side effects from treatment? When will their neurologic symptoms worsen? And as providers, we're always thinking about things like, well, what do I have next in line for therapy, and so on and so forth. And so I think highlighting that theme of time is just so important. So a little bit about CNS metastases. We think about sort of two large buckets. We have parenchymal or brain mets, which are the most common intracranial tumor in adults, accounting for over 50% of brain tumors. Generally, survival is poor and in the order of about 4 to 8 months. However, this is influenced by primary tissue type. The most common solid tumors that spread to the brain include carcinomas like breast and lung, as well as melanoma. The rate of involvement varies by primary tumor type, but can be as high as 16 to 20%, such as in lung cancer. However, based on large autopsy series, we know that in fact the rates of CNS involvement by disease is actually much higher. So one large series found that over 60% of patients with lung cancer have CNS involvement by disease at the time of death. LMD goes by many different monikers in the literature. So you may see it referred to as carcinomatous meningitis, leptomeningeal carcinomatosis, and ultimately what it represents is a late stage complication of cancer where you get multifocal spread to the arachnoid, subarachnoid space, and pia mater. Ultimately, any type of tumor can cause LMD. We can see it from solid tumors, liquid tumors, as well as primary brain. And on average, about 1 to 5% of cancer patients are diagnosed in the US each year. Left untreated, the survival is exceptionally poor in the order of weeks. And with treatment, we hope to extend life by 2 to 6 months. But ultimately, it's an incredibly neurologically morbid and fatal disease. Breast cancer tends to have the best prognosis. 13 to 25% of patients will have survival at 1 year, and that goes down to about 6% at 2 years. The most common solid tumors that go to the leptomeninges include adenocarcinomas like breast and lung, followed by melanoma and GI tract malignancies. Poor prognostic factors include patients who have a poor performance status, those who are neurologically extremely ill, so those with extensive neurologic symptoms, encephalopathy, if the CSF shows elevated levels of protein or they have very bulky disease on imaging, and the presence of a systemic disease as well is a prognostic factor in addition. Over time, the incidence is only increasing. This is in part because we have better imaging modalities to capture disease. We have an improved ability to treat our patients, and they're living much longer and having better extracranial responses. In addition, this may then lead to the reservoir of tumor cells in the CNS. And our therapies, unfortunately, have a pretty difficult time penetrating through the blood-brain barrier, in part due to high molecular weight. So overall, this is becoming more and more prevalent as we continue to progress through time. So how do patients present? Well, I thought I'd start off with share a patient story of mine. So this is a 26-year-old woman. Over the course of about 4 to 6 weeks, she developed progressive headaches and then intermittent right-sided paresthesias, which then progressed to involve intermittent movements of the right side of her body, affecting her arm more so than the leg. She went to the ER and had a non-contrast head CT done, and this actually showed a subarachnoid hemorrhage. She went on to have a workup for that, including CT angiogram that demonstrated no vascular abnormalities. They then went ahead and got an MRI of her brain, and that revealed diffuse enhancement of the leptomeningeals. Some of this was hemorrhagic in nature, but not all of the enhancement was due to blood products. Some of it was true enhancement of the leptomeninges. So ultimately, patients do present as a result of a space-occupying lesion and its surrounding vasogenic edema. And ultimately, it comes down to your neuroanatomy in terms of what you ultimately see in patients. With leptomeningeal disease in particular, though, much to most neurologists' chagrin, patients have a multifocal localization. So we see lots of cranial neuropathies, meningeal irritation, cerebellar symptoms, Cauda-Equina syndrome, sometimes reticular pain, as well as the development of hydrocephalus or increased intracranial pressure, as well as pressure wave phenomenon. So back to our patient, with those right-sided episodes, we had to try and figure out what they were. Were they something vascular, like a stuttering TIA? Could they be epileptic? She was placed on seizure medications with no response to the episode's frequency, and she had multiple investigations done to evaluate for those diagnoses, and they all came back negative. And ultimately, she was diagnosed with pressure waves or plateau waves. And I wanted to bring this up because it's an often misdiagnosed entity in patients with leptomeningeal disease. And so about 26% of patients with LM will develop increased ICP with or without the development of hydrocephalus. Patients with LM and increased ICP can have these transient neurologic attacks, and they're attributable to this phenomenon called plateau waves. First described in the 1960s, essentially these are paroxysmal elevations of the intracranial pressure becoming extremely elevated, about 25 to 72% above mean ICP, and they have a very sudden onset and offset. So patients have these very short-lived neurologic episodes. And during these episodes, what essentially happens is their cerebral perfusion pressure drops, and in the setting of intracranial pressure rising. And this leads to episodes that can very much look like a stroke or a seizure, where we see alterations in consciousness, tonic posturing of extremities, nausea, vomiting, as well as urinary or fecal incontinence. And these may be triggered by changes in position. And they typically last for a few minutes, and then the patients completely resolve in between episodes. And the management for this is very different to how you manage seizures or strokes. And so that's what I wanted to sort of highlight. So how do we further work up our patients and evaluate them? So neuroimaging plays a very key role. So ideally contrast enhanced MRIs of the brain as well as the entire neuroaxis, so the total spine as well. Systemic staging is incredibly important as well. It's going to help influence how you ultimately do decide to move forward with treatments for the patient. So ideally a CT, chest, abdomen, pelvis, or PET scan at the time as well. Biopsy and resection, tissue is always helpful. However, it does play less of a role in LMD and much more of a role in CNS metastases, such as brain mets. And as part of the NCCN guidelines, in addition to your exam and neuroaxial imaging, ideally you do want to get CSF on these patients as well. It can be helpful for multiple reasons, including evaluating for pressure as well as for looking for cytology. So LPs have been around for many decades now, but unfortunately, they're a pretty poor sensitivity test with 54% positivity with the first tap, going up to about 85% with subsequent taps. Ideally, we diagnose patients with positive cytology results. We can also diagnose patients who have clinical findings along with positive radiographic findings. And then oftentimes, I think we're in this sort of situation where we have patients who have signs and symptoms of LMD, and the CSF just isn't conclusive, and we know they have a malignancy. So some of the CSF findings that are suggestive can be a pleocytosis, elevated opening pressure, high protein, and low glucose. You can interrogate the CSF for certain tumor markers, and also use techniques such as flow cytometry, FISH, PCR, and IHC. However, oftentimes this is still insufficient in making the diagnosis, which is why I think there's been an increased shift to the utilization of advanced diagnostics, including next-generation sequencing and tumor cell quantification. So for our patient from earlier, she went on to have 2 taps. Both times there was negative cytology. She did have a pleocytosis, and she had normal glucose. She had a PET scan done of her body, which did not demonstrate any sites of disease in the body. And she had an MRI spine, which also demonstrated LMD. She went on to have a brain biopsy, as well as next-generation sequencing done on her CSF, as well as the brain biopsy too. And ultimately, but the CSF and the brain biopsy yielded an NRAS and GNAC mutations. Ultimately, using next-generation sequencing, which varies from platform to platform and can be whole genome, whole exome, as well as targeted panels to look for specific mutations, helps us understand what's happening in the spinal fluid. It helps us see how tumors can clonally evolve in the spinal fluid as well as the brain, and especially in patients whose histology is very uncertain, such as in this patient who was unable, despite a biopsy, to have a histologic diagnosis, can yield mutational information that helps us understand what cancer type it most closely aligns with, and that can then influence treatment. For a moment, just shifting gears to a different patient, here we had a patient who was 64, had stage 3B non-small cell lung cancer that was EGFR mutant. She was diagnosed in November of 2022, and a couple months shortly thereafter started an osimertinib, which is an EGFR targeted therapy. A couple months later, she started to have headaches, initially thought to be due to the osimertinib. However, they very quickly progressed and became extremely severe. She had multiple ER visits and acute care visits for the pain, and repeated neuroimaging, including MRIs of her brain and spine, were completely normal, with no evidence of disease. So we decided to do CSF evaluation, and she had 2 LPs. No whites were ever seen. No cytology was ever detected. A positive cytology was detected, but she had very high protein and very low glucose. Again, such suggestive that something's happening in the spinal fluid. We then sent it off for tumor cell analysis. There's no standardized platform for this, and this varies from institution to institution, but ultimately, CTCs, or CSF tumor cells, are thought to have shed from the primary tumor stroma. They can live in the spinal fluid, and essentially you can use either epithelial-based capture fluorescent arrays or use cell surface protein marker detection platforms to identify these cells in the spinal fluid. They can be interrogated for things like PD-L1, and they can also be interrogated for mutational analysis, such as HER2, for example. So they're incredibly valuable. And in this patient, who has otherwise pretty bland CSF and very negative neuroimaging, we were able to detect nearly 8,000 tumor cells in her spinal fluid. Because of this test, she was able to go on and actually receive tumor-directed treatment, which not only helps in terms of survival, but more importantly, was able to palliate her symptoms and provide her with pain relief. So how do we approach treatment for our patients? Here, I like to think of it again as sort of twofold approach, but ultimately all things come together. The first sort of major important thing we need to address is symptomatic treatments. So in terms of symptom relief, how can we manage our patients? From a medical perspective, we use drugs such as steroids like dexamethasone. We can use Diamox, which is a carbonic anhydrase inhibitor to help decrease CSF production. And we can use neuropathic pain medications as indicated. Surgery is ultimately the only way to improve neurologic morbidity. However, this plays a much larger role in brain mets than it does for lepto, which is a disseminated disease, which ultimately can't be surgically managed in the same way. However, things such as a VP shunt placement for hydrocephalus and plateau waves can be incredibly important. Radiotherapy also can play a role, especially in patients who have urgent symptoms and need palliative symptom relief. So our patient from earlier ultimately ended up having a VP shunt placed, and her pressure waves completely stopped, and she had no further episodes. In terms of tumor-directed treatments, and Dr. Thompson sort of reviewed quite a few of these with you, and so I'll sort of briefly review them with you again. We sort of have 4 sort of major arms in terms of how we can treat patients. So radiation, surgery, systemic chemotherapies, and intrathecal chemotherapy. Starting a little bit with systemic chemotherapies, historically, we've used drugs such as methotrexate, capecitabine, temozolomide, Avastin, pemetrexed to use for treatment of LMD. Most of these therapies are unfortunately going to be limited, though, because of their inability to penetrate through the blood-brain barrier. That's shifted in recent years to newer systemic treatment strategies that include tyrosine kinase inhibitors, antibody drug conjugates, and checkpoint inhibitors. So a little bit of a review again, with clear oncogenic driver mutations such as EGFR, ALK, ROS1 translocations, and non-small cell lung cancer, we can use tyrosine kinase inhibitors to directly treat patients that way. The first generation of these drugs did show improved progression-free survivals in relation when compared to traditional chemotherapy for patients with systemic disease. However, for CNS disease, we saw high rates of resistance mutations develop, high rates of CNS relapse, and just ultimately poor CNS penetration altogether. Newer generations of these drugs, such as second generation, but most especially third generation drugs like osimertinib, played an incredibly important role in the treatment of LM. The AURA study demonstrated a median OS of 11.1 months, which is incredible when you think about these numbers in comparison to historical data. For HER2-positive breast cancer, the incorporation of tucatinib has also opened up more doors for patients. A lot of this data comes from brain mets, but we can extrapolate some of it to a degree clinically for patients with LM. In this study, patients received tucatinib, trastuzumab, and capecitabine versus placebo with trastuzumab and capecitabine. And almost 50% of patients in the tucatinib group did have brain mets. the risk of disease progression or death was 52% lower with tucatinib, and the estimated PFS at 1 year was 24.9% with tucatinib versus 0 in placebo. I highlight this study not only because of its important therapeutic value, but because of its clinical trial design. This study actually allowed for enrollment of patients with untreated or previously treated but progressing brain metastases. And again, this is a population that's largely excluded from clinical trials. So I think it's an incredibly important study from that perspective as well. Another important breast cancer study is this Tuxedo-1 study, which was a phase 2 study of trastuzumab deruxtecan using an antibody drug conjugate. These therapies are able to go to a specific target and then drop off a payload to result in cellular death, essentially. And in this study, they found an intracranial response rate of about 73.3%, which is incredibly remarkable. Immunotherapy, which Dr. Thompson sort of did a great explanation on already, looks at primarily at checkpoint inhibitor therapies, though can also include vaccines and T-cell transfers as well. In terms of checkpoint inhibitors, these are antibody drugs that are specifically generated against CTLA-4 or PD-1 or PD-L1, and they've shown very durable responses in patients with metastatic melanoma. From a CNS perspective, we see that an over 50% intracranial response rate with the combination of nivolumab and ipilimumab, which is pretty good. In terms of intrathecal regimens, ideally we have an Ommaya reservoir placed by our neurosurgical colleagues, and we can distill drugs directly into the nervous system, primarily using drugs like topotecan, thiotepa, trastuzumab, as well as methotrexate. But here, patient selection is incredibly important. So patients who have very bulky or nodular disease are not ideal candidates for IT treatment because the disease will lead to impairment of drug flow. And when that happens, we'll have increased rates of neurotoxicity. So though this is an incredibly valuable tool to have in the clinic, we need to make sure we're always selecting the right patients. And building on this has been a really important phase 1 study out of melanoma that's looking at a combination of concurrent intrathecal as well as IV nivolumab for the treatment of LM specifically. In this study, they seek to determine the safety of intrathecal nivo along with what the recommended dosage would be, as well as a look at overall survival. And they found that the ideal dose of intrathecal nivo is 50 milligrams. And in addition, they saw an OS benefit of 4.9 months, which may sound small, but in the world of LM is quite remarkable as well. Radiation plays a very important role in the treatment of leptomeningeal disease. Traditionally, we use involved field radiotherapy, so using whole brain radiation or radiation to the cauda equina, but ultimately, there are very high rates of relapse. And when you think about it, it really makes sense because you're only addressing one part of the compartment and not the whole compartment. And that's where proton-based craniospinal irradiation is incredibly valuable. A randomized phase 2 study by Yang et al. Showed that proton CSI provided an OS benefit of over 9 months, which is remarkable. The other reason this tool is so valuable is that it minimizes organ toxicity because of how the proton beams work and how they deliver radiation therapy to the thecal sac. An important part of that becomes the bone marrow sparing properties of proton craniospinal irradiation, which then allows oncologists to continue or provide additional systemic treatment options to the patient, because marrow toxicity is one of the largest issues with radiation therapy. Surgery, though historically has not played a very large role in the treatment of LM, I think is increasingly becoming important. One modality that's incredibly interesting to think about is the use of focused ultrasound techniques with microbubbles. So here, we have a therapy that may allow for the circumvention around the blood-brain barrier. Using an ultrasound combined with a circulating ultrasound contrast agent called a microbubble, we can temporarily and reversibly open the blood-brain barrier, and then we're then allowed to provide treatment which can hopefully reach the CNS better than it would have otherwise. This is a study here that looks at athymic rats with that were injected with breast cancer cell lines to develop LM, and those rats, went on to get treatment with no treatment at all, trastuzumab only or trastuzumab with focused ultrasound and microbubbles. And what they saw was that the development of LM was slowed in the group that did receive trastuzumab, and it was further decreased in the group that received trastuzumab with focused ultrasound and microbubbles, and those rats lived for much longer than those who had otherwise not received treatment at all in particular, but also just with the Herceptin alone. And the actual volume of the tumors formed were much lower in the trastuzumab with focused ultrasound and microbubble group as compared to trastuzumab and control. So this is going to be a very important emerging strategy for the treatment of LM. So back to our patient from before. So she, after the shunt, went on to get proton craniospinal irradiation, and she then went on to get treated with ipilimumab and nivolumab, both checkpoint inhibitors. And now she's about 8 months from diagnosis and continues to be with us today with no neurologic deficits, which is really quite remarkable. And just sort of, going back to time. So how much does time matter? Well, I've been thinking about this a lot, and I think time can also be thought of from other perspectives. And I wanted to sort of give you a little food for thought. So the choroid plexus, which is incredibly important part of the nervous system that leads to the formation of CSF, may play an important role in not only how LM is formed, but also perhaps how we can detect disease. So CSF essentially dilutes metabolites from neuronal activities. Its production and resorption are regulated dynamically and are central to maintaining brain homeostasis. And so the choroid plexus ultimately leads to the formation of the blood CSF barrier. It's the major source of CSF production, and it harbors a circadian clock. So the choroid plexus forms spinal fluid at different, not only rates, but different products at different times of the day. And so we've seen this play an important role in neurodegenerative diseases like Alzheimer's, but from a disease perspective, from a cancer perspective, it does make you wonder if the time in which you get your CSF, what impact does that have on your diagnostic yield? And if you're treating patients intrathecally, does your treatment response get affected by the time of day that you actually provide patients with treatment because of what's happening in the choroid plexus? And along those lines, there has been some interesting work that's looked at time of day in terms of treatment and response. So this was a study that was published in 2022 that looked at patients who were getting checkpoint inhibitor therapy with nivolumab for metastatic non-small cell lung cancer. And they found that patients who were treated before 12:54 p.m. had 4 times the response rate as compared to patients who received treatment after. And there's also emerging reports about this for chemotherapy in ovarian cancer and metastatic colon cancer. So I thought it's a very interesting way to also think about time and what we're doing and the impact that may have on patient care. Ultimately, I hope to leave you with with this important message of how we need more clinical trials for our patients. We do need to stop excluding them from these studies. We need to learn how to incorporate the advanced diagnostics into routine clinical practice. And ultimately, we also need to learn how to sequence our multimodality treatments. Thank you so much for having me.
Thank you so much, Dr. Milani. That was just a great talk. Very difficult and humbling topic to end with. And I know that we don't have a lot of great tools in our toolbox in order to manage leptomeningeal disease in a way that doesn't cause significant morbidity. But I feel like we are moving the needle a little bit, as you pointed out, with the advent of additional intrathecal therapies, perhaps better opportunities for more focused radiation or even proton therapies. There was that randomized trial that had come out, and especially in a pediatric population, that's become critically important. And I know one of the ending points that you made was inclusion of more of these patients in clinical trials. Can you describe perhaps some opportunities of clinical trial opportunities that are coming down the pike specific to this issue?
Yeah, I think with LM, it's probably going to be lagging for some bit, but in particular, we're seeing changes with brain mets, I think. And so the inclusion of more brain mets patients into these large studies, particularly in breast cancer, such as HER2 or there was very recently a non-small cell lung cancer paper that came out in ASCO that looked at atezolizumab with patients with brain mets. And again, just sort of learning that, just starting to incorporate, I think, more neuro-oncologists as well as part of the clinical trial design to be able to help sort of manage some of the neurologic symptoms that may occur, and evaluating the exams, I think are all going to hopefully help shift to also then including more LM patients further down the line into more of these studies.
I think that would be great. We've concluded the second half of our panel. Obviously, we're moving into the panel discussion. So I don't know if it's possible for all the second half panelists to put themselves on video again. I did have a question for Dr. Tewari as well. And a lot of this question comes on the heels of the White House actually just having submitted an executive order with regard to the appropriate use of AI. And I know it's such a huge buzzword in our fields right now, especially with radiologic imaging. What do you see as kind of the ethical pitfalls or the safety associated with utilization of this brand new technology in the utilization of these tools specifically for looking at the difference between necrosis versus progression? It's not like we have FDA approved tools yet to utilize this, and some of these tools that we use, even the sources of data could sometimes be questioned with regard to how those AI tools are actually built. But was wondering if you could comment on that, especially as that's become kind of a popular issue within the press these days.
Sure. So I'll break down your questions into two parts, and then I'll answer the two parts. So first is about use of AI in clinical practice and some of the considerations that we need to have, right? So there's onus on the developer's part, which is, some of it I covered in my talk, sort of thinking about reproducibility, making sure that the tools that you're developing are reproducible, that it's not, the results are not sort of, it's not hallucinating, it's actually truly representing what it means, right? So trying to capture the underlying biology. So a lot of that has to be done before it gets to prime time, where it gets to clinical use, right? So we have to do our due diligence in the background to make sure that these approaches are well validated. And so that's why we tend to be careful, especially in the context of radiation effects tumor recurrence. We know that it's really mixed pathologies, right? It's not really A versus B, it's really A and B together and the same lesion. And so how do you account for that? And the fact that the ground truth has to come from histopathology, where we get resections, we get pathologists to read this and tell us what their assessment was. In fact, in one of the studies we did, although we did not have the luxury of large data sets, we did have a small study where we had multiple pathologists read the pathology slides and call it, over 80% tumor recurrence, over 80% radiation effects. So we had some confidence in the way we were building these models, where we said, okay, at least the pathologists think, multiple pathologists think that this is over 80% radiation effects tumor recurrence. So we're comfortable with calling it class A versus class B. But then we did another study where we were also looking at mixtures of, let's say, 40% radiation effects and 60% tumor recurrence, so maybe something else in between as well. So to be able to quantify some of those things and not really think of this as a black box. And I think that's why we need regulations, checks and balances in place, because if it's a black box, then very often it can make a stupid mistake. And, it's very hard to tell what's happening. It may be able to identify some very intricate fine patterns, but it might just miss a cancer, which is obviously, by visual assessment, you can tell. So it makes some of those errors that we need to be careful about, and there needs to be checks and balances in place. And then to go back to your other point about, things that we need to consider is also the racial differences. Gender differences is one thing that I covered, but I didn't necessarily talk about racial differences. And that's also a big aspect. If your entire training population is Caucasian, then you can't assume that the model is going to work on African American population or Asian population. So that's another aspect that people are looking at more and more carefully as we are trying to build these models and then starting to think about clinical practice. And then this is the first aspect. The second aspect is about your question with respect to radiation effects and tumor recurrence. One thing that we need to be careful about is when we are training these models that we should not miss patients who have tumor, right? It's okay to miss patients who have radiation effects and call them tumor because they will get a biopsy, they'll get a surgical resection. But if we are ultimately claiming that these models should avoid biopsies or resections, then we need to have absolute confidence in making sure that the patients who have radiation effects who have tumor are not called as having a radiation effect. So that's one thing where your sort of sensitivity, specificity analysis comes into play, and how we train and build these models.
I guess I would also add that one of the nice things about radiology, at least, is that we can often test new things next to our whatever we're using as our standard of care. So we have what we would do as our standard of care, and then we have the AI doc thing open, the little program that looks for fractures or looks for hemorrhage and other things as well while we're still doing our clinical practice. And we can disregard that, or we can say, well, we don't trust that, or we don't believe that, and we go on with our clinical practice. But I can tell you several times the AI doc has caught things that I've missed. And so that has awakened me to make sure that I pay attention to that, at least have it be part of what I'm scrutinizing. So you can put these AI technologies next to what you're doing in the clinical realm. And obviously, that gives you the opportunity to see how good they are or how accurate they are.
I have a question for all the panelists. I think we very well described this heterogeneity, how Dr. Tiwari put her ultimate situation, right? Here we will have the radiomics, we'll have the genomics, and we'll predict that how would this person be treated. How do you consolidate that paradigm with that kind of granularity to a clinical trial that wants to homogenize everything, only enrolls people? The main reason people with brain mets got excluded from these large trials because the survival was different once you have a brain met, and they didn't want to alter the results of the clinical trial. As a result, that population just was not getting included in these big trials. So how do we consolidate this need to do big clinical trials to these granular differences between specific mutations, specific genetic variation, race, gender, all that we're including in?
I mean, I can speak from the machine learning perspective, but I'll have someone else talk about the clinical trials. But from the machine learning perspective, ultimately, as I was saying, we need diverse data sets. We need large data sets so the model knows the differences and it can pick up those differences. So for us, it would make, when we get to that point, and I know we're not there yet, and that's why we've not looked at racial differences, just because the data, it's very often we're dealing with Caucasian population primarily, and so it's difficult to get African Americans and other sort of race specific disparity or diversity in the models. But ultimately, that's what we want to get to. And so I guess I'll pose it to the others, people who do clinical trials, and sort of answering the other aspect of the question.
Yeah, I mean, I talked a little bit about this in my talk. I don't know if there is one solution that'll answer all of these questions at the same time. But as clinical investigators, we certainly have opportunities to interface with trial design, whether it's with collaborations with pharma or cooperative groups, or our own internally designed trials at our own institutions, and there, in designing our inclusion exclusion criteria, that's where we can become advocates for being, for including patients with, again, starting easy asymptomatic low volume brain mets, and trying to push for more inclusion of those patients on trials like this. It'll probably be harder with some groups than others, but I think, if we don't make the efforts, it'll never happen. And then, continuing to feedback to these groups that the data that exists. I mean, if you've ever talked to these groups, they always point to their CNS control based on, they'll do these subgroup analyses and try to point to them as well. Look at how great our CNS data is, but they're incredibly flawed because all these patients are previously treated, and so with local therapies, so we really don't know the activity of a lot of our drugs in the CNS. But and then in terms of incorporating the other modalities, radiographic or AI based, again, I think that's a great effort, and again, maybe best done through multi-institutional, cooperative group or those types of more collaborative efforts than it will be through pharma. But
Yeah, I just have the comment that to use RANO criteria alone is not sufficient. So yeah, we do need to do a better job with how these are designed from an imaging standpoint as well.
Yeah, I agree with that too. I think the conundrum with having CNS or patients with CNS metastases on trials is just, as we've discussed even this morning, the absolute heterogeneity with which these patients present with, and then the distribution of those metastases. John, you and I share multiple patients where, we said, well, what about systemic therapy alone? But, this patient's lesion is right next to their speech center in the brainstem. And, what may be described as low volume disease, it's low volume disease, but in a critical location that maybe we would want to do focused therapy first and then let the systemic disease be, or the more microscopic disease be managed by whatever systemic therapies you're going to offer. So I think the challenge lies in the heterogeneity of these folks. That's going to be an issue.
yeah, no, I completely agree. It's not, there probably isn't one size fits all solution, but either the criteria have to be extremely granular, thoughtfully designed, or allow some flexibility with treatment and sequencing it. But it's a challenging situation.
I agree. I did have one question for Dr. Berenice. I get really excited when I see these PET agents coming into being described in phase 1-2 data sets. And then every time I go and think I have a clinical application for this, I get immediately shut down by the insurance company or immediately shut down saying they don't have access to it. What's the long range plan for getting these agents that have clearly shown clinical efficacy into more the mainstream for community oncologists to take advantage of to help decipher some of these conundrums?
Yeah, that's a really good question. So the flucyclovine and the FAT-PET are on their way towards FDA approval. And so once you get that FDA approval, at least in that specific patient population, the insurance coverage should be a lot easier. That being said, though, we were successful by working with the various insurance companies and basically not taking no for an answer. The clinicians would advocate and say, look, my patient needs this. We have this question of, increasing enhancement. The MRI is not specific enough. This is, recommended. Some of it is recommended by NCCN guidelines and other advocacy agencies. And so, having these conversations with the physicians during the peer-to-peer, we've won them over, and we've learned how to talk to them. We keep things pretty simple. Just say the word PET. Don't say which tracer, because then they get all confused about which tracer does what. And the combination of PET-MR, you don't even have to say PET-MR. Just say that we need the PET, and then just sort of simplifying it. A lot of ways has helped us get around some of the denials. I actually, believe it or not, the number one reason for insurance denials is that most insurance companies don't want the patient to get another MRI exam within a month of the MRI exam that they've already had. So we discovered that early on, that was denying the PET-MR exam because it had an MRI component. It had nothing to do with the PET. So that was an interesting thing we uncovered. So we stopped ordering exams within a month, and that overcame a lot of that. So those are sorts of examples where the more you deal with insurance companies, the more you realize there's a physician there, they're pretty smart, you know, when they listen to your side of the story on a peer-to-peer, and over time those peer-to-peers reduce, they go down, especially the more aggressive the clinical services when they order the studies. So so that's one thing. The CMS uniformly improved the PETMR for us. So there was no negotiation with CMS in terms of getting a PETMR for brain tumor patients. So if you have patients that are getting Medicare, Medicaid, then those should go right through without any issue. So knowing things like that is really important within the practice, and then really just really advocating to get those exams. I think where folks have found it extremely useful is in the radiation planning, both for the FET and the brain metastases, as well as dotatate for meningioma already here at UW. Some of the radiation oncology folks here at UW can speak to what their experience has been so far, but all of those requests have also been approved. So I think over time, the more physicians order them, the more they basically don't take no for an answer. And the more these become FDA approved, I think we're going to see this become much more common.
I appreciate that answer. I'll be sending you all my peer reviews from now on, if that's okay.
You know, the funny thing is I've always offered to be involved with them, but the clinicians do such a great job that I've never had to. I'd love to sit in on one.
Good stuff. Thank you.
All right.
I don't have any other questions from the audience either, but I wanted to, actually, I take that back. We have one, or one additional one. So I'm not sure who this was directed towards, but let me read it. When working with animal models, do you see the same or similar differences in gender that AI radiogenomic models for glioblastoma survival analysis sees? I'm assuming this is probably towards you, Dr. Torrey, or you, Dr. Veronese.
Yeah, that is a good question. So we haven't necessarily done the analysis ourselves on looking at preclinical models and clinical models. But one thing that we did notice when we were doing our analysis on the analysis, the retrospective analysis that we were showing on patients, that the associations that we find with more malignant phenotypes, that I was showing with men being associated with angiogenesis, cell apoptosis, and so on, that have been shown separately on preclinical models as well. So there is some sort of similarities in terms of the signatures that were emerging for men and women, both in preclinical models and the studies that we've done, although we haven't done the preclinical studies ourselves.
Yeah, and to add to that, on the PET side, we do see a gender difference in the uptake of the FET. So that's been shown clinically and in our preclinical models. So it definitely is something that needs to be taken into account.
Immunotherapy definitely works differently in like animal model of like the male versus female mice.
And even in humans, it's been shown, right, that there is sexual dimorphism in response.
Right, and we published that, like for especially DC vaccine, women tend to do better than men.
Well, this concludes our symposium. I can't thank our panelists enough for your amazing presentations and your amazing time and the knowledge that you've been able to share with us. Just sitting here for the morning, I've received countless text messages from attendees just saying how wonderful everything was today. So thank you to our expert panel. We couldn't have done this without you, and appreciate your time and expertise.
Thank you so much for having us.
Thank you for having us.
Sentiment. Thank you
Thank
for
you.
spending your
Thank
morning.
you.
And I would also like to thank Caleb, Tad, and Janelle for helping us organize this.
Agreed. We can't do that without the expertise of our IT staff. For those that are still in attendance, we will be sending out an evaluation form. Our panelists definitely appreciate these just for feedback on their own talks. We appreciate these as we do these conferences twice a year and always try to take to heart the recommendations that we get and make thoughtful changes to help make this the incredible forum that it's turned into for our brain metastases and central nervous system tumor talks. So be watching for that to come through, and we appreciate any and all feedback that we get on that. And we'll close out. Thank you guys so much. Take care.
Thank you.